information, something to take home. So before we go any further, I'm looking at the various presentations that we have. We're looking at diabetes, where we're going to refresh and reinforce, and we're going to sharpen our edge. It was mentioned earlier that we have been enlightened and refreshed, but now we are really sharpening. So we are going to be sharpened going into the latter half of the year. We're also going to be looking at de-stressing, because especially after all of us need to be de-stressed, not distressed, but de-stressed. So our first, and then we're going to be looking at decisions to consent by Dr. Caroline Pino. So our first presenter is Professor Michael Boyne, and he's a professor of endocrinology and metabolism in the Department of Medicine at the University of the West Indies, and an honorary consultant in the University Hospital of the West Indies. He received his honors, BSc honors in biochemistry, and his MBBS from the University of the West Indies. And after his residency in internal medicine at the University of Virginia, he completed clinical research fellowship in endocrinology, diabetes and metabolism at the Johns Hopkins University School of Medicine. He was board certified in internal medicine and endocrinology, diabetes, and metabolism. He's a fellow of the Royal College of Physicians of Canada, Edinburgh, and London. His research interests include how hormonal and nutritional factors in early life influence the development of the metabolic syndrome. He's a member of several associations, including the Endocrine Society, Development Origins of Health and Disease, Caribbean Endocrine Society, and the Association of Consultant Physicians of Jamaica. Please help me welcome Professor Michael Boyne with diabetes, where he's going to reinforce and refresh.
Okay. Good afternoon. I hope everybody can hear me. Just checking. Just let me know if you're able to hear and see me.
Yes, we can.
Okay, great. All right, good. So thank you for the invitation, very kind invitation. And as Dr. James has said, we go back a far way. We won't count the number of decades. Isn't that right, Dr. James? But I thank you for the invitation to come. And I was asked to give a sort of overview of aspects of diabetes care to reinforce for those who have already known quite a lot and to refresh for things which are new. And I noticed yesterday that you also had in your flyer about ethical dilemmas associated with diabetes care. So I made some modification to some of the slides. It's not just purely about outpatient management of diabetes, but some of the ethics and dilemmas that we have, especially as I put in there in a sort of resource poor setting, which is what many times we have here in the Caribbean. But make no doubt about it, it's also true that when it comes to diabetes, nearly every country is resource poor. So we'll talk a little bit more about that. And you see my affiliations, and also just in the interest of disclosure, in the past, since I have been mentioning a few pharmaceutical compounds that I've received educational grants to go to international conferences from AstraZeneca, Eli Lilly, and Novartis. So with that in mind, let's press along. So what I think many of us will recognize is that diabetes is a very significant problem, especially for death. So in our country, this is Jamaica, some data on Jamaica, you see that from 2009 to 2019, stroke has remained our number 1 cause of death, but there is diabetes right behind it, number 2. So we do have to acknowledge its importance in the livability of Jamaicans. And when you look at what risk factor drives now, not just death, but also disability, we're going to see that elevated glucose is the number 1 cause of death and disability combined. So it is something that we are going to have to continue to see going forward. I discovered that over the years, many people not so interested in how many people died, but they're also interested in money. So here's some conservative data assembled about the impact of diabetes across the entire Caribbean. And this data is now even dated since it's 2015. And I say conservative because the estimates themselves are conservative. But if you count up the costs for the microvascular complications, retinopathy, nephropathy, neuropathy, and the macrovascular complications, cardiovascular disease, peripheral artery disease, stroke, and you add them all together, the direct costs because of treatment and complications, and the indirect costs, you will see these numbers and what that amounts to. And remember, this is millions of US dollars. That's approximately 1.5 billion US dollars that diabetes causes the Caribbean in 1 year, in both direct and indirect costs. And for those of us as clinicians, of course, we're interested in human suffering, that over 22,000 people die and over 30,000 years of active life loss is going to occur. So diabetes is something that can bankrupt everyone. So I keep telling people, and I'm going to remind this group, because this is some of the challenges that we have, that every year for us in the Caribbean, we need to find $1.5 billion, and there are going to be 22,000 people who have died because of diabetes. And I remind you again, this is a conservative estimate. So because of that, with these sort of numbers, I like to tell people that everyone here, whether you're a surgeon, pediatrician, internist, family practitioner, nurse, pharmacist, whatever you are in the healthcare sector, we need to know diabetes, we need to know blood pressure, we need to know lipids, we need to know weight management, all of us. Now, in today's talk, we're not going to be covering blood pressure and cholesterol because we're going to speak more about aspects of glucose control. And I'm also going to assume that when we talk about it, we're also maximizing lifestyle, what is needed to be done for lifestyle, but it's going to come across a little bit more. Now, there's various data that show that we in the Caribbean are a little bit different than some of the other persons in the world. And we hope to show this at the Olympics in Paris next week, isn't that right? So, but when you compare data for, say, persons who are Caucasian versus persons who are Afro-Caribbean versus persons who are Asian Indian, you can see that there's differences in how we have also have complications. So in the Caribbean, we tend to, and the Caribbean people are emphasized there in red, the red bars. The risk for myocardial infarction is less than our Trinidad Indian or Indian Jamaican population. But we also have higher rates of stroke. We have higher rates of, or lower rates of peripheral artery disease, but we have higher rates of nephropathy. So there's going to be some difference. And there's been a lot that has been come about this, that we have significant differences compared to other populations. Same disease, but the manifestations can be slightly different for a variety of reasons. And even many researchers locally have looked at this. So some of the conclusions that we have reached in general, 1 in 7 Americans, right, is going to have diabetes. And this is up from 1 in 20 about 5 decades ago. In the Caribbean, it's 1 in 8, right? So 1 in 8 of us, I see that there's about 400 of us here online So utilizing those numbers, approximately 50 of us may have diabetes and we may not even know it. 40% of all young adults existing now will be diagnosed with diabetes at some time in their life. And as has been said, there's no device, no drug powerful enough to counter the effects of poverty, pollution, stress, broken food systems, cities that are hard to navigate on foot, and inequitable access to healthcare, particularly in minority communities, in the sense that our entire society, Jamaica, land we love, is perfectly designed to create type 2 diabetes. And that's one of the problems that we have to go against. We're not just fighting a disease, we're also fighting a sort of way of life, the way we're living life right now. And of course, that's going to bring some ethical dilemmas. So medical care alone won't halt the spread of diabetes. This is a socioeconomic problem that's creating a huge public health dilemma. And the social determinants of health in terms of access to care, social acceptance of disease, economic stabilities of communities, access both to education as well as to healthcare, our built environment, all of these are going to be involved in the combat against diabetes, which is one of the reasons why it is so difficult to do. So I want to tell people, even I'm not speaking mostly healthcare individuals, a personal message. Are you at risk of diabetes? And we all are, because we all live in the same environment. And so we have to try our best with lifestyle, getting enough sleep, always difficult, social connections, etc., to help prevent the onset of diabetes, as well as we too, like what we tell our patients that they should get tested, we ourselves as healthcare providers should also test ourselves. So let me give you a thing as we talk about persons being diagnosed with diabetes. And there is a little bit of an issue here that has emerged over the last several years. So here's a case of a 52-year-old accountant who has a 5-year history of hypertension and has just had an annual executive. And what I found was that his fasting plasma glucose was normal, less than, it was 5.1. And his hemoglobin A1C was 6.6. And the definition is that normal is going to be less than 6.4. Above that is the definition of diabetes by some groups. So I'm going to ask this August group, what would you do next with someone like this? Would you start them on metformin? Would you just tell them, no, don't worry about it. You're normal. We don't need to look at these information. Would you do some further testing, such as a 75-gram oral glucose tolerance test? Would you order a 2-hour glucose after breakfast? Or would you repeat the numbers, right? Because he has one that says a fasting, which is normal, and the other one, an A1C, which says it's abnormal. And in the interest of time, we're not going to go through this, but you yourself can make a personal decision of what you would like to do. But I'm going to tell you what the right answer is. And it is not to tell him that he is necessarily normal. It's not necessary to state pharmacotherapy. It's really that we would need to confirm the diagnosis by an oral glucose tolerance test. And it's not to take a 2-hour blood glucose or just to repeat the numbers. Now, why do I say that? And it's a nuance that's something that I get called about all the time, and many people don't seem to recognize. To diagnose diabetes, you can diagnose it using an A1C, and if it's more than 6.5%, you can use a fasting plasma glucose if it's more than 7 on more than one occasion. You can do an oral glucose tolerance test, which is regarded as a gold standard, and that's should be 11.1. Or if they're having symptoms of diabetes, they could do a random, which would be greater than 11. Now, even though these are acceptable conditions, one thing I would like you to know is that in our Caribbean people, relying only on the A1C to make the diagnosis many times is actually not useful. We tend to run slightly higher A1Cs, people of color, than Caucasian individuals. So we tend to run about 0.3 units higher than other persons, as well as also many of the labs are not standardized. So you take the same tube of blood to different labs, you're going to get different results. And therefore, you have to do no harm by trying to give a person a disease where they may not have that disease. And so the proper way to look at that individual is actually to do the gold standard, even though it's inconvenient, and to do an oral glucose tolerance test and to be certain before you classify them as having diabetes or not. So the take-home message, be careful in an asymptomatic individual to only use an A1C in an asymptomatic individual. Now, I don't need to tell also this group that we are well aware that we should treat diabetes significantly, right? So you'll do harm if you do not treat that person's hyperglycemia. And there have been multiple studies around the world that have shown that by treating aggressively persons with diabetes, you decrease their microvascular complications, their risk for heart disease, their overall mortality. One or two studies have not shown that or even an increase, but the vast majority have shown you definitely improve microvascular complications. You can vascular complications and mortality, but it's actually better that you work on their their blood pressure and lipids at the same time to get a reduction. So we do recommend that you should benefit your patients by treating them. Now, are there insights on how we should treat our persons with diabetes and some of the issues that might be involved there? And I'm going to do a little bit of physiology or pathophysiology, like how do we develop type 2 diabetes? And many of you might know this sort of slide that, here, if you have an individual who was diagnosed around here with diabetes, at this point in time, they were diagnosed. But generally speaking, for many years before, they've had a problem with insulin resistance going up as they got obese and more sedentary, more westernized lifestyle. And that put a strain on their beta cells, and their beta cells started to compensate, but then they start to decompensate. And so when an individual is diagnosed with diabetes at this point in time, they have significant insulin resistance. They have a heavy working beta cell, and the cells are disappearing as time goes by, so the function is declining. So the thing that a lot of us don't remember, that we should also communicate to our patients, it's a progressive disease. So as time goes by, the beta cell dysfunction and beta cell mass keeps declining. And because of that, diabetes is a progressive disorder. So what worked in the control today doesn't work as well tomorrow. And it's something we need to tell our patients early in the disease. Otherwise, they believe that they are a failure. Well, it's true, maybe they're not trying as hard. But at the same time, they need to be aware that this is an evolving process. And because it's evolving, need to be prepared and flexible to move. And that's one of the reasons why some patients don't move, because they think that they are a failure, so to speak. Now, and we've shown that this is also true in Jamaica. So here, when we look at some Spanish Town data from Spanish Town, where you are, we found that when we looked over 4 years, persons' insulin sensitivity didn't change that much. Those who developed glucose intolerance and diabetes, but found that their beta cell function declined a whole lot. So right there in Spanish Town, you confirm that same data. And by now, this data is even over 20 years old. We also know a lot more about diabetes, and it's not meant to confuse you, but just to reinforce that we spoke about the beta cells and insulin resistance, but there are multiple tissues that are involved. So for insulin resistance, we have liver, we have muscle, we have fat that are involved. We spoke about that beta cells can be declining in function, their mass. We also know that the kidney can be involved, and the glucose, it reabsorbs more glucose, maintaining hyperglycemia. The stomach rapidly increases glucose, driving up the blood sugar. If you have a lot of inflammation in your body, that drives up your blood sugar. The gut microbiome is also now a big player and very popular, and something that we are all speaking about, as well as our brain telling us one, appetite control, our urges and not, but also our sympathetic nervous control. And nearly nowadays, we have medications that can not fix, but address nearly all of these areas. But because I showed you that the beta cell can decline over time, and you should tell your patients that diabetes can and will get worse over time, can we do anything to preserve it? Because this might affect our selection of treatments. And as far back now as 20 years ago, we know that persons who are using thiazolidine downs like rosiglitazone do better over time. They tend not to decline as much that you need to add a second or third or fourth line drug than someone who's taking metformin and then somebody who's taking a sulfonylurea. So not all drugs are exactly the same. They can slow down diabetes deterioration. Even intensive insulin given in newly diagnosed persons can also help to keep them from deteriorating in their glycemic control. And not only that, but just flipping through dapagliflozin, a relatively new kid on the block, it's been around 10 years, pioglitazone and liraglutide. These are all agents that have been shown to change the natural history of diabetes. And we also have more of an impetus because data done in the UK, but involving 500 Afro-Caribbean individuals also shows that if we start early, people are better off. So if persons start to reduce their blood glucose from diagnosis, the day you diagnose that individual, you start working on it. Those persons that even years later, if they relapse, they have a 7-fold lower risk of developing diabetic complications and death compared to somebody who delayed their diagnosis and waited around for several years. So it's telling us that we really need to work fast, and that creates a dilemma, because the dilemma that we have all around the world, but especially here too, is what is called clinical inertia. And I'm defining clinical inertia here. Clinical inertia is a failure to intensify treatment of a patient who is not at their goal as per the guidelines, whatever guidelines you're using, Ministry of Health, CARPHA, American Diabetes Association, British Diabetes Association, whatever guidelines that you have to be using. If they're not at goal, have you intensified their treatment? Since we are seeing that treatment early and intensively makes a difference. As well as the guidelines are saying, if they're not doing well, you should make a decision in 3 months and move on. So, but are people doing that? Well, unfortunately, there's a lot of clinical inertia. And here's some data that was done in the United States, but I'm sure we can replicate the exact same thing here, where persons who were first started on monotherapy, then they weren't doing so well, they were advanced to dual combination therapy, then they weren't doing so well afterwards, so they put on to triple therapy, then they weren't doing so well, so they're advanced to insulin. And as you can see, as their A1C, they started monotherapy, the A1C improved, then it deteriorated. And then afterwards, they started combination therapy, and then it improved, and then it deteriorated, etc. But the delay is not months, the delay is years. The average time to add a second agent was nearly 3 years. The time to go on to triple therapy was nearly 7 years. And the time to go on to insulin was another 7 years. So everywhere there's a failure to be aggressive in the treatment. And what happens if we're not aggressive in that treatment? Well, here's the risk of developing complications in individuals if you lower their A1C over time, aggressively from diagnosis, and you keep it down with a sort of, no inertia, you're working at it, compared to the person who is doing like what I showed in that last slide, where there's a lot of clinical inertia. At the end of several years, what you'll find at the end of 5 years, that the persons who were unfortunately in the hands of a physician who practiced clinical inertia, their MI risk was 67% higher, stroke risk was 50% higher, heart failure 64% risk higher, kidney disease 43% higher. So we are failing our patients if that's the case. So clinical inertia is an ethical dilemma. Now, one of the issues as we dig down is that intensification of therapy is also associated with some risks, right? They may have side effects from this. They may be financially distressed because it's cost them a lot of money. And so we do have this dilemma, should we intensify, or do we not want to overtreat the patient or have side effects, which is called, one ethical principle of non-maleficence, right? But basically, what's happening generally worldwide with diabetes, there's a culture of, fear of causing some harm to the patient over the benefit that the patient can have. And this culture is what is pervasive and preventing patients from being aggressively treated. And therefore, they suffer many of the complications that cost us so much problems here in Jamaica. So my cardiovascular friends tell me that when you have heart disease, minutes is important. Time is muscle. If you're having a heart attack, get to the hospital quickly. And we also have it now for stroke, that time is brain. Get to the hospital if you're having a heart attack very quickly. But I can also want to make you think that time is pancreas, that generally we have about 3 months when things are not going well to make a difference. If not, we will continue to have $1.5 billion in direct and indirect costs, 22,000 deaths per year in the Caribbean. So we need to personalize our treatment. And when we do personalization, we're trying to now take clinical trials data and look at everything about the class of the medication, the drug specifics, and try to tailor it to the patient, thinking about various things, which can be complicated at times. What's their heart doing, their kidneys doing, their A1C, are they overweight? How old are they? We're thinking of multiple issues, and we're trying to make a decision. And I hope that you're starting to realize that, treatment of type 2 diabetes is more than just bringing down the number alone itself, because we want to prevent the progression over time to persons. So there are multiple drugs. I just put on a few of them on the slide that one will have to decide upon how to select and help our patients. So the physicians are thinking about mechanism of action, as well as what are the potential side effects. We have to be known about know how efficacious it is, how strong or potent it is. Is it bringing out fasting or post-meal glucose? Is it going to cost them an arm and a leg? Is it available on formulary and non-formulary? So there's this variety of decisions that one has to make. And there's also that ethical dilemma where, depending on the drugs you use, you are also trying to decide on, as I try to bring down their A1C and produce benefit, I may be raising the risk of hypoglycemia, especially if you're using now sulfonylureas and insulin. Not to say that you can't use them, but there's this balance. Because if we didn't have that problem, I could just give everybody 1 million units of insulin and they'll be fine. But I know I'm going to cause hypoglycemia. So how do we kind of get this balance? And that is a dilemma that one has to, as we balance both benefit to the patient as well as avoiding harm. So here's another patient for the clinicians who are amongst us, that, here's a 58-year-old civil servant. He has rheumatoid arthritis. He has hypertension. He's using medications. And his fasting blood sugar now shows a fasting glucose of 11.3, which is obviously elevated, and an A1C of 8.4. So now we have two parameters which are confirming that the person is diabetic. So I'm going to do no harm by telling the person now that you are diabetic and we do need to treat you. They're a little bit on the overweight side. They don't have any complications. Their ECG is normal. They don't have any microalbumin in their urines, nothing for nephropathy. So now we have the dilemma of what options can we choose? Lifestyle, actually we just do lifestyle only. You use metformin, lifestyle plus metformin, use a DPP-4 inhibitor, DPP-4 inhibitor plus metformin, a sulfonylurea plus metformin, some other types of drugs, because there's so many to choose from. What are we going to choose from? And I'm hoping to give you a little bit of guidance over the next several slides. But one of the things that when you're choosing them is that we also have to tell our patients, where is our goal? Where do we want to see you? Do we want an A1C less than 7, which is the average for some people? But there are certain factors that you may want to use a more stringent A1C. So suppose the person is newly diagnosed and they're very, very young, right? And they have no comorbidities, we may want to, in those, bring them down to 6.5 or lower. But suppose that person is elderly, or they have cancer and their lifespan is, dramatically shortened, or comorbidities such as heart disease or stroke, etc. You may want to be less stringent with that person. And therefore, you may want to offer an A1C closer to 8%. But you should make that decision, discuss it with the patient, and document it also for other healthcare providers who may be coming after you. And when you're interacting with the patient, of course, it has to be a holistic approach that involves the patient's characteristics and needs. So we as healthcare providers may assess their lifestyle, their comorbidities, their weight, how high is their A1C, if they're depressed, and their social determinants of healthcare. We need to now determine what sort of regimens we're going to use, whether they're going to be complex or more simple, the access, the cost. We need to involve the patient in a shared decision-making where we discuss also their personal preferences, ensure that they understand what we're talking about, and we have a common goal in that mind. Then we should agree on a management plan that is SMART, specific, measurable, achievable, etc. Implement the plan, encourage a patient to be involved, monitoring their sugars at home, monitoring their blood pressure, their weight, etc., and to come back and be reviewed and do the whole process all over again. This is an iterative process that has to go through the lifespan of the patient. Now, we do have some dilemmas to also, should we give them, I showed you that patient, should we give them monotherapy or combination therapy? Well, the answer is really, in a sense, combination therapy, because what the guidelines are saying, we should always have lifestyling. And we should also add metformin. So that I call combination therapy, lifestyle plus metformin. And lifestyle, of course, involves nutrition, their physical activities, stress reduction, how much sleep they're getting, the environment they live in. And lifestyle should be relatively cheap, although we know food policy can change this and certain types of diets can be more expensive. Weight reduction to improve their cardiovascular health is good for cancer prevention, microvascular disease prevention, as well as reduce mortality. And metformin, I always tell people, if the person is not on metformin, why aren't they on metformin? Because it's cheap, it promotes weight stability, does cardiovascular benefits, it may have cancer prevention benefits, benefits the microbiome, and reduces mortality. Although you can have some complications, such as GI upset, and if they're using it for 10 years or more, they may have low vitamin B12 levels. So things that we have to discuss and also evaluate in our patients. Now, I get called all the time about people trying to say, I have this dilemma about what should I do with my patient? And I'm trying to balance things. So now nearly every algorithm is unfortunately slightly complicated. So I apologize ahead of time. But I'm put up this algorithm here because I thought that maybe I could highlight some things that might help you in your decision making and as you discuss with the patient, because this should also be a discussion with the patient. So take, for example, if the patient is overweight or obese, then we should try to use agents that are going to promote either weight stability or weight loss. And those are GLP-1 receptor agonists, which are not readily available in Jamaica, and SGLT2 inhibitors, which are readily available in Jamaica, although not necessarily always on formulary. And we'd want to avoid sulfonylureas in those cases because they tend to promote weight gain. Now, suppose the person is different in that maybe it's an elderly person, lives alone, and you're worried about them having hypoglycemia. Who's going to attend to them? Then in that sort of dilemma, then again, SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4s, or thiazolidines are again good options, but you might want to avoid sulfonylureas. You may also have another aspect of cost. Cost is very important. Well, sulfonylureas and pioglitazone are more cheap, so we'd probably prefer to use them more than using an SGLT2 inhibitor or other agents which are more expensive. And I'd also just want to let you know that if the person has severe hyperglycemia, their blood sugars are extraordinarily elevated, you may not even want to play around with tablets. You may want to just move straight on to promoting insulin therapy in those individuals using basal insulin. Now, if your patient has a diabetic complication, we may want to modify that, because up to 20% of persons, when they first see you, will have a diabetic complication. So let's suppose they have heart disease. So if they have heart disease, ischemic heart disease, coronary artery disease, then an SGLT2, if they can do it, is great, or GLP-1 receptor agonist. If they already are known to have heart failure, right, whether clinically or echocardiographically, an SGLT2 inhibitor is pretty good. And if they've had a stroke or a TIA, and I'll also add to this list, fatty liver, then GLP-1 receptor agonists or pioglitazones are also preferable. And if they have kidney disease, then using an SGLT2 inhibitor is also preferable. So also knowing what's going on, but that means you have to think about your patient, you have to talk to your patient, and make a decision afterwards. And that's something that you have to do. So here's another dilemma that people always ask me ethically: should we start combination therapy at diagnosis, or should we, in terms of using more than one drug, or should we add on as time goes by? Well, we're changing in that. And one of the things, such as the Verify study showed us, and there's some data that if we start our patients with combination therapy, metformin plus something else, whatever that something else, in this case, the Verify, they use a Vilda study, they found that they were able to keep the patients at better control using low dose combinations, and they did not need to add a third agent for a very long time. Matter of fact, it gained them more than 2 years of not needing to advance their treatment, which of course, time is money and such like. So again, it's a principle of early aggressive treatment can also help to have benefits later on. And what is the best second line agent to use? Well, people ask this all the time. What about sulfonylureas? Not a week goes by, somebody, should I have a sulfonylurea? Well, some of the data in general suggests that when we use sulfonylureas, adding or switching to them, not to say that they're bad drugs, but the risk of hypoglycemia and heart disease actually goes up. That's what this little forest plot is trying to tell you. Now, this is all sulfonylureas combined together. And I'm not certain if this is a class effect, like it's all sulfonylureas, or certain sulfonylureas are better than the others. And some of the data suggests that glycoside is better than, saying, glyburide. So again, if we're selecting drugs and we have the option, then glycoside might be a better combination than glyburide. But overall, sulfonylureas themselves are not as great as some of the other options. Other data like this is suggesting is that pioglitazone and incretin therapies like DPP-4 inhibitors and GLP-1 receptor agonists, these tend to achieve and sustain better control over the next several years. And again, that people don't need to add another agent when you compare it to persons using sulfonylureas or insulin. So these data are kind of helping us to evolve in our thinking of what we are going to offer our patients. But the only real head-to-head study that we have where we pitch several agents against each other is a GRADE study. And what they did in the GRADE study, they looked at persons who are on metformin and lifestyle not doing so well. They offer them either glargine or glimepiride, a sulfonylurea, or liraglutide, a GLP-1 receptor agonist, or sitagliptin, a DPP-4. There was no GLP-1 receptor, SGLT2 inhibitor in this group. And what they were trying to find out is, if you look at the deterioration of their diabetes or their weight gain, because nobody wants to gain weight, or having hypoglycemia, which of these drugs perform the best? And what they found was that liraglutide was better than sitagliptin, better than insulin, better than a sulfonylurea. So again, as clinicians think about what we offer people, what does no harm is actually given a little bit of a hierarchy based on data like this. So I come back again. Every year, we're trying to prevent $1.5 billion in the Caribbean for being spent on diabetes, and to prevent 22,000 people from dying from around the islands. But here's my last point that I want to make. We spoke about clinical inertia as a major ethical dilemma. There's also another ethical dilemma. And I'm going to show it to you in this one, and it's about adherence. And what do I mean by that? So over the last decades, data from many different countries has shown that the percentage of people who have good control of their diabetes, have an A1C less than 7%, not improved. Right? Despite all these new drugs, all these options that we haven't even spoken about things like glucose monitors and insulin pumps. So we have a lot more technology being thrown, a lot more expense being thrown. Have we made their A1Cs better as a population? So here's American data. So it was, the number of people who were at control was about 57% then, and it's about 51% now. So we've not made a lot of improvement. And when you start to drill down, what you tend to find is that when we look at clinical trials, and we say, oh, in this clinical trial, we've reduced the A1C down a lot. When you look in the real world, we don't see that. So take, for example, here is a GLP-1 receptor agonist, which in clinical trials lowers the A1C by 1.25%. But in the real world, data only shows about 0.5%. It's not as great as we saw in clinical trials. Even DPP-4 inhibitors lower about 0.7%, in the real world, only about 0.5%. So why is there this gap? Well, most of that gap is due to poor adherence, right? Meaning that persons may not necessarily get the same reduction as we see in clinical trials because their adherence is poor. And adherence, what they're meaning that the number of times they fill the prescription that would guarantee that 80% of the time they would have taken the medication, right? This doesn't count the amount of times they actually swallow it, plus the amount of times they fill it at the pharmacy. So they fill it enough to cover 80% of the period. And most of the lack of efficacy is because patients are not able to adhere to it. Only a small amount is due to, biological factors and interference from other drugs. And why is this so? Because we have the ethical dilemma of financial constraint. We are offering patients treatments. They may not have the social support. You give them a basal bolus insulin regimen. They may not be able to support that and to have the family support for that. The regimen might be complex. We may not have generic options that are available and efficacious. We are not sitting down and having time for the consultative process in the clinic to describe the treatment and educate our patients. And patients may have fear about various aspects, things that they want to talk about. Have we given them the time and the space that they can make these decisions and therefore still reinforce their autonomy while we try to help them get the best glycemic control we can? So because of that, after about a year, less than 50% of our patients are adherent to their medications, and less than 25% are persistently taking their medications. And these are sobering numbers why we have such a big problem. So in summary, I just want you to remember the death toll and the suffering that people are suffering. Remember the cost to Jamaica. We all need to be diabetologists. Because no matter if you're on surgery, I can guarantee at least a quarter of your patients are diabetic. If you are on obstetrics and gynecology, similar 25%, etc. So we all need to know about diabetes. Time is pancreas. Why are we waiting? We need to decrease our clinical inertia. We need to try to preserve our beta cells, and some of our newer drugs can do that. Care is not just only about glucose control, but we need to think about our patients. We have an obligation to think deeply about our patients and to make the best recommendations given information as well as the patient's input. Diabetic complications, we may need to think of some of the newer and also more costly drugs, but you at least need to consider that. But just to remember, clinical inertia, patient non-adherence, socioeconomic factors are very important and form part of the ethical dilemmas that we have for diabetes care. So that's all that I have to say. Thank you for your attention, and I turn it back over to the moderator.
Thank you so much, Professor Boyne. Thank you so much.
You're welcome.
I can tell you there's so much takeaway in your presentation this afternoon. And if nobody knows what your ABC is in diabetes, I can tell them it's A1C. If they don't know that that is your ABC, then they would have had nothing else from this presentation. And at the time, it's brain, it's muscle, it's brain. And then later on, it's pancreas. So very profound. I'm sure we're sharpened by your presentation. And I just want to say thank you, so we could sit here and listen you further. But time is of the essence, and we're trying to get the other presenters in. Thank you once again. And we will have a question and answer sessions. I'm not sure if you'll be able to stay with us after the next presenter. Then we will have some questions that I'm sure you will be asked of you from your presentation. Thank you. So our second presenter, it's becoming a household name in our Spanish Town webinar. But to introduce her, I am going to call on Michaela Robinson, and I did not select her. Michaela Robinson to come and introduce our next presenter, who is Dr. Stephanie Reed. And Dr. Stephanie Reed will be sharpening our edges in risk intelligence. Over to our final year medical student, Michaela Robinson.
Good afternoon, everyone. Thank you for tuning in. My name is Michaela Richardson, and I've been given this lovely opportunity to introduce a Dr. Stephanie Y. Corinthian Reed. So Dr. Stephanie Corinthian Reed is the former Chief Executive Officer of the Savannah Lamar Hospital, Cornwall Regional Hospital, Bermuda Hospitals Board, University Hospital of the West Indies as well. She's an expert in health administration and health systems, and she also served as a consultant to the Ministry of Health in St. Vincent and the Grenadines, Ministry of Health Tortola in the British Virgin Islands, St. Lucia, and Trinidad and Tobago. She served as co-chairman on the Conference Board of Canada, a member of the American Hospital Association, and the International Society for Quality in Healthcare. Dr. Corinthian Reed served as advisor to the Minister of Health and Wellness, and currently is consultant to the Ministry of Health and Wellness. Dr. Corinthian Reed developed and designed the Masters of Science in Health Administration program that is currently delivered by the University of Technology, Jamaica, and is a senior lecturer and program director for the course of study. She also develops the Healthcare Professional Leadership Training Program that is being offered to healthcare leaders in the local healthcare system. Dr. Corinthian Reed currently is a consultant in the Ministry of Health and Wellness and leads the Compassionate Care Program. She has affiliations with the Johns Hopkins Hospital, the Howard Hospital, the Howard University Hospital, the Medical University of South Carolina in the USA, and the Sunnybrook Health Services, the South Lake Regional Hospital, and Niagara Health System in Canada. She's also an alumni of South Bank University in London, the Harvard School of Public Health, and the Medical University of South Carolina in the USA. Thank you so much for joining this webinar, and I'll hand it over to Dr. Corinthian Reed.
She hasn't started to share yet. Dr. Reed, are you there? Hi, Dr. Reed.
Just want to say thank you to all the participants while we wait on Dr. Reed to get started out. I want for you to just go ahead and fill out the Google form so that you can get your CME hours while we wait on Dr. Reed to start her presentation.
I am on, yes, can you hear me now? Can you hear me now?
Loud and clear. Thank you, Dr. Reed. Welcome.
Thank you for having me. I've tried to condense what I have to the, was it 30 minutes or 40 minutes that I have to see how much I will be able to do this afternoon. Okay. Sharpen your edge. And I like the title because in our healthcare system, I truly believe that we should be sharp, we should be on the ball. And as I keep telling everyone that I talk to, we have a health system that will respond to our needs, but it's going to take effort, our effort, to get it to where we want it to be. So this afternoon, I'm sharing with you a very close topic to me and one that I love to talk about, and it's healthcare risk management. We want
Sorry,
to look,
Dr. Reed, just a
yes.
minute. Can you just turn on your video, please, so we can see you?
Oh, all right.
Thank you.
Okay. Can you see me now? All right. I won't keep it on too long because my internet at this side is not very strong. All right. Okay. So we are looking at how we can intelligently manage our risks in our healthcare system. And I like the fact that I am dealing with one hospital, the Spanish Town Hospital, because again, I feel that it is important that we start. We don't have to think of the entire region to start. We can start in our own health facility. All right. So I want to make it simple this afternoon. Let me get to where I can. Okay. No, something is going wrong here. I can't move my slide, and I should be able to do so. Not sure what is happening. I don't think I want to spend all afternoon troubleshooting.
Do you want us to
Great.
project from here? Okay.
Yes, I have it now. I have it now. Okay, so we're going to look at risk intelligence. What does that mean to us? And maybe I could ask somebody on the platform, what does risk intelligence mean to you? Anybody want to respond? Nobody want to respond? Okay. When we talk about risk intelligence, what we are talking about is how we intelligently assess our situation in our healthcare facility, the Spanish Town Hospital. The need to identify areas of risk is very important to us. Therefore, we have to make that effort. Spend the time, bring the team together, and start seriously considering and identifying the risk factors that we have to deal with on a daily basis. Risk factors that, if they are not dealt with, can result in serious situations that have negative implications for how we deliver care to our patients, and even how we manage on a daily basis in our hospital. Okay. So what risk intelligence does, it actually aims to align risk management with our organizational strategy. All right? It is the solution that helps businesses, right? And remember now, everything we do in our hospital, right? It's all about the business of health. All right. So risk intelligence is a solution that helps us to regularly identify, right, and avoid or manage the impact and duration of risk. Looking at how we deal with the incidence of risk and ensuring that all stakeholders become a part of the solution. So with risk intelligence, the hospital can gain visibility into necessary information that will help you, help the team, help management, right? Identify and quantify and manage your risks. Now, this is not a one-off activity. This activity should be carried out constantly. In verifiable manner. What we mean is that you need to be able to verify those factors that you identify as risk in your hospital. And I know on a daily basis, you're up against these factors out there. What you do as you continue to work, right? Continue to deliver care, continue to work as a team, address the situations as you go along. You have to be very mindful of the potential hazards right there at Spanish Town Hospital. The potential hazards that can result in situations that is untoward. Now, I have here a short list. And at the top of the list, you see patient safety. I should also include staff safety, all right? Patient safety. There are risks to our patients. And it is important that we identify those risks and manage those risks carefully. What about our processes? Anybody can identify any type of risk in the processes that we utilize. All right, I'm going to leave you to think about that, and I'll be coming back to it later. What about the incidents and accidents that take place in our hospital environment, right there at Spanish Town? Do we have incidents? Do we have accidents? Are we able to identify the causes? Are we able to document accurately what happens? Are we able to see, to understand the reasons why we have these incidents? Do we take time out to assess each situation and actually turn those situations into tools for learning? What about adverse events? Does the Spanish Town Hospital experience adverse events? Yes? No? I'd love to get an answer. Do we have adverse events at the Spanish Town Hospital? It could be once a year. It could be many times a year. Do we have adverse events?
Would that bomb threat count as an adverse event?
Could you repeat for me, please?
Oh, sorry. I was asking if the bomb threat that happened last year, would that have counted as an adverse event?
Yes, it would account as an adverse event. Didn't it disrupt your whole
Recent
production?
hurricane.
Did it disrupt your production for the day or days?
Right. So the recent hurricane and the flooding.
Yes, the recent hurricane, yes, and flooding, if you had flooding, yes. In fact, did you have electricity after the hurricane? Did you have electrical power?
Yes. We had our generators.
You had your generators, thankful for that, right? But just think of all the disruptions that the hurricane caused. Also, there are disruptions when you get a bomb threat, all right? All those are incidents, all right? Adverse, and there are adverse events. Are there any adverse events you can think of? Any other adverse events?
Patient hitting a staff, curtailing the time we spent in clinic.
Yes, what did you do about that? How did you manage that?
Shut down and debrief, shut down and vent.
Okay, that's the only thing you did?
Yes, other things that happen.
Help me out here. Kind of walk me through what happened and what you did. Go ahead.
Yes, Dr. Reed, if I may, we do have incidents or incidences in our A&E department, also in our outpatients department. What those incidents caused was that we looked at our processes and we got persons involved. We have them involved and we look at our processes and see what could be changed. Outside of us just calling the police, we have our meetings, we invite all the stakeholders and see what measures could have been put in place. Because of course, we know that when we prevent, then that medicine is better than the one that we take after.
That is so true. Yes. All right. So it is important, and you document. Was there any need for you to develop a policy to guide the staff in those situations?
There are policies in place, but what we do, we look at what we need to adjust in the policy and document.
Right. Yes. Yes. All right. We're looking at, you know, those factors that can cause risk for us. Yes. What about medication errors? How do we deal with that one? All right, can't think of.
Yes, when we do have medication errors, we look at what happened, how it occurred, and we also look at refresher. And we would have documented that these persons who were involved and also involving others to prevent again. So we would have refreshed persons and sharpened them as well.
Okay, so what you do, you use the event as an opportunity to retrain your staff, retrain the team.
Certainly.
Okay. All right. Infections. And I'm very interested in this one because I remembered, I think it was just before COVID, I had a student who was actually doing the research, looking at specific types of hospital acquired infections. And I know this is one of the ongoing activities that you'd want to manage closely, want to ensure that you are monitoring and on top of this particular activity. All right. Then we have industrial disputes. Do you see that as a risk hazard? Or maybe we don't have the type of industrial disputes that lock down our hospital. Have you ever thought about it as a hazard, a risk hazard? Just think about it. If there is a dispute, an industrial dispute, persons not working, all right, they may be out, not working, or they may be at work, but not working. What happens next? What happens next? Do you have a smooth flow of operation? Are you able to get through all that you have to do for your patients timely when you have an industrial dispute? Think about those things, all right? Then what about supplies? Do we have situations where we just can't get the supplies that we need? I see a hand up. I see a hand up. Yes, I'll take your response. A hand is up. All right, I will continue. Supply chain failures. I'm sure that we do have problems with supply in our hospitals, and I'm sure that Spanish Town Hospital do have problems with supplies. How does that impact on how well you can provide service? How does that impact on your productivity in your healthcare space, in your healthcare setting? All right, and I have also financial failures. When we don't have the funds to get the things that are needed in our healthcare system so that we can provide service. All right. So what we want to do is to ensure that the Spanish Town Hospital can be transformed into a risk intelligent enterprise. What you're doing here is looking at how you can align risk management with your organizational strategy so that you can have what is called an integrated approach. You can develop that integrated approach to risk governance. We're going to talk a little bit more about risk governance. But when we have in place risk governance, what we're doing is enabling a risk intelligence enterprise. Now, this is very important because in many situations, we try to start programs and movements such as risk management, such as quality improvement, and we are not getting the backing of the highest level of leadership in our organization. And that's not good. All right. So we're going to speak to risk governance. We're going to step back and look at it. And when we're talking about the risk governance structure, we are talking about your hospital management committee. We are talking about senior management and executives, senior administrators. All right. This is very important for us to recognize that we can't do it alone. So for instance, for the medical group, you'd have your SMO who leads the charge. Yes, she leads the charge. It doesn't mean that she's going to do everything. She can delegate. But because she leads the charge, it makes a difference in how the medical clinical services are supported by the risk governance structure. For the hospital to have a strong risk management in place, the CEO must be fully involved and other senior directors. In addition to that, your hospital management committee that has the highest level of leadership, right? And that committee is also legally authorized in ensuring that the hospital, the Spanish Town Hospital, functions effectively. So you can't leave your hospital management committee out of this movement. And I call it a movement, all right? They have to be a part of what is happening. They are the highest level of governance in your hospital, and they should be involved. Now, what does the governance structure do? It supports the Spanish Town Hospital risk intelligent effort. All right? So you start your risk management program. You are able to proactively identify the risks that are there in your hospital. You have to plan to manage the risk. In fact, your planning should start on what it takes to mitigate some of these risks. All right? So that's where your risk intelligence effort starts. An effective plan to work with. Effective strategies for your risk intelligence effort. And these strategies should be aligned to Spanish Town Hospital strategic goals. You want to ensure that you are organized. You want to ensure that you can set the priorities. All right. You want to ensure that you identify the capabilities that you have. And you also want to be sure that you can avoid the common pitfall that takes place in your hospital. And I have to talk about the silos, because even up to now, we have not gotten rid of the culture where departments tend to work on their own. A characteristic of your hospital or any of the other health system in Jamaica and the world is that units depend on each other. No one unit, no one group can fully provide the care that the patient needs. It is always a team effort. And therefore, when you're planning, when units are planning, they have to think about the other units that they impact on or that impact on them. You have to do that. The accident and emergency department cannot plan fully without thinking about the support it needs. It needs the support from diagnostic imaging. It needs the support from the lab. It needs the support from the medical records department. So there's no way you can plan and actually come up with an accurate and practical strategy to get your emergency department going without thinking about, or not just thinking, but collaborating, right? Having discussions with the other units that you depend on. All right? The same thing with the lab. The lab cannot function by thinking that it is on its own. It is not. It depends on other units that will use its service. All right? So when the lab plans, it has to plan in collaboration with all those other services that will utilize the service of the lab. So one thing I want us to remember is that the silos, planning on our own, in our own department, not thinking about other units that will impact what we do, is planning to fail. That's the greatest.
Bye.
That's the greatest pitfall that we do have. And we're still continuing. I don't think we learn as yet how well there has to be integration of efforts in order to get the job done, in order to have an effective risk management in your hospital. Just a little more about the Hospital Management Committee. As I tell you before, that they are there, they are legislated. That means they are legally placed at the head of your hospital and all the other hospitals in Jamaica. All right? With the exception maybe of the regional hospitals that report directly to the regional committee, the regional board. All right? Now, the Hospital Management Committee has to govern risk effectively, but the committee cannot govern risk effectively if you're not talking about it at those meetings. if you are not presenting at the hospital management committee with regards to the risk, the possible risk that you have to identify and manage in the hospital setting. Committee members must be involved. The CEO's office must be involved. It can't just be the SMO's office alone. It can't just be the nursing director's office alone. All right, it is a combined effort. And we must demonstrate that combined effort. You should be able to present to your hospital management committee all the various possibilities for risk in your hospital. What are the risky areas? And you don't identify an area and say, okay, ICU is risky, right? What about ICU that that have you identifying the ICU as a unit, right? That needs urgent and close risk management. You have to identify, you can't just be general. You have to identify those factors that are the risk factors that you will have to manage, you have to deal with, you have to plan for. All right? So to govern risk effectively, management, the CEO, right, administration, all right, your medical administrator, your SMO, your nursing administrator, all right, your director of nursing has to be fully a part of the group that manage risk. That group that is always assessing the environment, the hospital environment. That group that is looking at possible factors that
5 minutes more, Dr. Reed.
Wow, that can be a problem to how well you can function. There has to be a practical approach to risk governance. And the operational discipline to implement the approach at the unit level or the operational level is very important. Now, the role of, we continue, when we look at the management of the hospital, there are 3 questions that you have to really deliberate on. You have to ask, you have to deliberate on. All right? Do we currently exercise risk governance at the operational level at the Spanish Town Hospital? Can anybody answer that? Do we currently exercise risk governance at the operational level at Spanish Town Hospital? Given the fact that you know that risk governance include your hospital management committee, the CEO's office, your SMO's office, your director of nursing office, and maybe other senior directors that should be on such a team. Do you currently exercise risk governance at the operational level? Can somebody quickly tell me? You do,
Our
you're breaking up.
CEO, the SMO, the Director of Nursing Service, Hospital Administrator, instructs monitoring officer, the circumstances that
Okay. So do you have in place? So
chairman
do
of
you?
the board, the hospital board is on this meeting, the webinar now, Dr. Reed. The
Great.
chairman of the hospital board.
Okay, that's great. All right. Now, how can we better align risk governance with risk management throughout the entire hospital? That's another question that you're going to have to deliberate on. You need to be able to align both at the governance level and the management level, risk management throughout the hospital. That means every department, right? Every area should not just being aware that there's a risk management, but know that there's a risk management, know the role they play in the risk management function. And on a daily basis, they adhere to the policies that govern risk. How are you on that one? Quickly, do you need more work there? How are you on it? Or you're good? Not getting an answer, I wish I did. Okay, the third one, how can we drive risk management into our day-to-day business practices? Does that make sense? How can we ensure that daily in our practices, we are practicing the policies to ensure that we can manage risk? Are we doing that? All right, so those two areas you will have to, I'm not thinking that you're not doing it, but I'm thinking, are you really going with that? Or there is improvement that you can do? Now, one of the things that we need to do, right, starting from the governance level, right down to the operational level, is to get rid of the silo approaches that we use in our health system. It can't be that it's just my department alone, I think. And so from time to time, and the changes that are taking place in the health system call for more integrated approaches to thinking, more integrated approaches to problem solving, more integrated approach to developing strategies, and so on. More integrated approaches in how we assess our performance. Okay, units must be aware of the importance of other units, not just being aware, but appreciate the importance of other units so they can draw from them, each unit drawing from each other. We need to ensure that there is a more enterprise-wide view and approaches to risk. It can't be for just a few departments. It must be for all the departments, all the units, all the services. And that should be greater understanding of the systems approach. Greater understanding of the systems approach to identify problems. All right, and there was a response speaking to medication error, that you have to ensure that you look at all the processes that takes place, right? From the time maybe the medication was prescribed to the time the patient gets the medication. You have to, I always recommend that you use your fish, you know, the fishbone diagram, your cause and effect tool to help you to identify the cause of the problem. Unless you are going to go away with the symptoms of the problem, and then you have the problem occurring over and over and over. So greater understanding of your systems approach, using your tool, your cause and effect tool to identify the problem. Very important. Then the decision-making process must be collective where appropriate. All right? Where it needs a team in this decision-making process, you should have it. Not just a one person making a decision for a one unit. Not sure what is happening here again. My slide is, how much longer do I have? I did cut down the slides.
Time has been up a while now, Dr. Reed. We were just waiting for you to just wind up.
Yes, I am almost through. I'm
On your
almost
last,
through. Yeah, I'm
figure
almost.
you're now on getting to your last slide. But we know we're going to have to invite you for a workshop.
Well, yes, because risk management is not really something that we can do quickly. It really means that we have to have some time to spend in order to ensure that we are working. When we have the risk management lectures, there are more practical lectures that help us to understand more about risk management. So I spoke to the role of management and the hospital committee. I also spoke to the role of the committee of management. Yes, I did that. I'm just going down to maybe the last few slides. We talk about getting rid of the silo approaches, exercising risk governance at the operational level. And remember that at the operational level, that's where we get things done. That's why it is so important that we always consider the operational level. All right? We talk about aligning risk management, right, throughout the hospital, not just a few places, right, exercising the concept of risk management, but every unit right across the board. We need to ensure that risk management also is into our day-to-day practices, And for those, I think Spanish Town Hospital may have a contractual services where the ancillary staff or the porters, please, you have to get them. You have to get them as part of the group that you are training. All right, because they can affect the business practices if they're not trained. We need to, when we are talking about integrating risk management into the day-to-day business practices, this is where we are getting down to the policies that we should have in place. All right. And many times we lean on the Ministry of Health policy. Always remember that the Ministry of Health policy is a global policy. What we need to do is to develop our own organizational policies. Our own organizational policies that will also speak to the idiosyncrasies in our organization. All right. Policies that speaks to the uniqueness of the Spanish Town Hospital, why it is so unique, and why we have to be very strong, not only strong and alert when we are speaking to risk management. All right, our protocols, the tools that we need to work with. You can develop your tools, all right, to work with. You can ensure that your team is working, right? And you can come up with methods that you can utilize to assess your risk in your health, in your hospital, especially at a time when you have overcrowding in your hospital. All right. There are risk factors that you need to be mindful of and that you should be monitoring very closely. A very important area that I didn't put here is how you document. You must document your activities in such a way that you can go back to those documents at some point. And there is always need to go back to see what was done at any time in your operation. And that's where documentation comes in. Lack of documentation also heightens the risk. And your risk intelligence will inform you of that over and over, because at all times, documentation are expected, and you have to ensure that you have them in place. All right. Management responsibility. And I have two major responsibilities here for management. The team approach.
Dr. Reed, sorry, can you go to the last slide, or can this
That's the
be
last
your
slide
last?
I am on. That's the last
Thank
slide
you.
I'm on. All right.
Thank you so much. We're pressed
Okay.
for time.
I know. The management approach. All right. The team approach. You need to ensure that there is the integrated views of the team regarding risk, and there has to be coordination to properly deal with those risk events. All right. The second very important responsibility for management. Your leaders must lead the process. All right. And when you lead the process, you're also looking at the views that are coming from the team, from the persons who are involved. You're going to adopt those views because you're going to be able to take that very important information and go through that information and see how you can develop new policies from those experiences. All right. And as our nursing director says in this meeting, right? You look at your policies, you improve your policies and so on. It must be done in such a way that you know that what you are putting in those policies come from the input of the team. Ensure that all times your policies are in place, and you must respond. You must respond to the situations that you confront. And when you can respond and manage the situations, then you will expect and see best outcomes. Okay, I will leave you at that for this afternoon. And thanks for having me. Hope there is something you can take away.
Thank you so much, Dr. Reed. And there's so much to take away from your presentation. The units depending on each other and how the key, the importance of documentation and a whole lot more. I just don't want it to seem as if we're pushing for you to stop because we really would have wanted to hear more. But as we say, we have to arrange for you to come in for a workshop with us one day and maybe over a 2-day period, because there's so much more that we know we can get from such a presentation. We just want to say thank you so much. And we are now going into a question and answer section. I know that I didn't see any questions posted, but we have 2 poll questions that we're going to ask Dr. Palacio Cato to take us into that segment. So the first poll question is up, and we're asking for you to just take a minute and respond to the question.
Okay.
Which is not part of the goal of
Okay, so really and truly, there are 4 questions, 3 from our previous presentation done by Professor Boyne, and the next one is from our professor, from Dr. Stephanie Reed. So we're just giving you a few more minutes or seconds, sorry, to answer the following questions. So just to read them, the first one is, which is not a part of the goal of care in diabetic patients. So the first one is to utilize shared decision making, consider specific factors that impact the choice of treatment, to assess patients' comorbidities, or to do what is best for the patient without considering them. So which one is not a part of the goal of care in these diabetic patients? Next question, which is not a benefit of metformin? So you have gastrointestinal upset, weight stability, it's cheap, reduced mortality, and cardiovascular benefits. All right. Next question. Sulfonylureas are the preferred drug of choice in overweight or obese patients. True or false? And then last question, which is not a role of the hospital management committee? To oversee the day-to-day operations of the facility, ensure quality care and services are provided to patients, to address any issues or concern that may arise at the facility, or only risks that apply to the facility and not to the patients are brought to their attention. And I think we have, most persons have answered each question, so I'm going to end the poll now. Are we still there? Okay, so Professor Prof. Boyne, if you're still in the meeting, he's still there. I would like you to go through the following questions and give more insight of the answers. Or you believe, what's the answer? It's
Okay, so which one is not a part of the goal of diabetes of which is not a part of the goal of care in diabetic patients. So of course, it's very important to have shared decision making. It's very important to assess comorbidities and specific factors. I'm sorry, I just lost the poll, but can't see it again. Oh, yes. Assessing comorbidities, if they have kidney failure, then you may want to choose an SGLT2 inhibitor, etc. So there could be different aspects involved, a dietitian, what have you. But it's obviously very important to get the patient's point of view, which I saw 86% of people comment on, which would be the correct answer. You're like any aspect for any other disease, especially chronic diseases, patients need to be involved and motivated. You want them to be self-monitoring to get that mindset. And so they have to be fully committed, and therefore getting a point of view is very important. They may harbor fears or insecurities about the plan. So obviously that is the best one to choose. The benefits of metformin, it does make weight stable. It is cheap. It does reduce mortality. That the UK PDS study showed that very clearly, as well as it has cardiovascular benefit. It's not as great as an SGLT2 inhibitor or GLP-1, but it does have cardiovascular benefit. Also, pioglitazone has cardiovascular benefit. But yes, most patients want to stop the medication from GI side effect, and that could be just from a unsettling feeling in the stomach or queasiness, so to speak, versus diarrhea or altered bowel habits. However, some persons have used that to their benefit because it made them stop eating, so or eat less. So, but still, that would be the correct one: GI upset. And sulfonylureas, if you can avoid them in the overweight or obese patient, please do. The average weight gain when you start a sulfonylurea at 50% of the maximum dose. So 10 milligrams of glyburide, 4 milligrams of glimepiride, 60 milligrams of glycoside. The average weight gain is going to be 2 to 4 kilograms. So if you may not have a choice if the cost is an issue, but you would want to avoid that because of the weight gain. So I hope that's of some benefit.
Thank you so much, Professor Boyne. So Dr. Reed, if you're still here, we have one more question for you. If you could go through this question and discuss the answer. Gender. Okay, well, that question was really a given. You hear me? Can you hear me? Yes, that question was really a given. The answer is indeed, not only we want to look at the facility, but we also want to take in consideration our patients. And it's just to ensure that you guys are listening to the presentation, and 90% of you guys were. So thank you so much for attending our question and answer section. We will see you again shortly.
Thank you so much, Dr. Cato, for keeping us on our toes with those questions. Good job. So we move into our next presentation, and this presentation is on de-stressing, honoring our collective wisdom. I really think that this presenter needs no introduction. But for those who are joining us for the first time, I will now ask that we have Dr. Michaela Richardson introduce our next presenter, who is family, Dr. Wilma Fletcher Anthony.
Thank you. Hello, everyone, again. So, Miss Wilma Fletcher Anthony was educated at the Capella University, where she did a PhD in general psychology in 2006. Her dissertation was the lived experience of West Indian youth reunified with immigrant parents in the host country, a phenomenological study. She did her Master's of Education at Arizona State University in 1993 in Council of Education. She did her Bachelor's of Education at the University of West Indies in 1988 in Science Education. As for her licensing, she's a licensed mental health counselor, which she received in New York in 2006, and she still practices today. She's certified in telemental health training, and that was done in 2021. Professionally, she went to the Sam Sharp Teachers College in Jamaica, and she was a faculty member in 1989 to 1995, and became consultant on guidance counseling in 1995 to 1999. She went to the Queensborough Community College or the City University of New York, and she was a counselor from 2001 to present. She was also at the City University of New York Counseling Center, and she was assistant director in 2006 to 2008, and has since been promoted to senior director since 2019. Finally, Professor Fletcher Anthony also has 6 publications over the period of 2006 to 2019. Let's give a round of applause for Professor Fletcher Anthony.
Hello, Spanish Town Hospital. I'm so excited to be back. I am family by definition and relationship. And it is really always delightful to be a part of what you're doing. This is really exciting work. So I was asked to talk about de-stressing, and it would be really pretty easy for me to come and deliver a lecture on de-stressing, but that I didn't think would have the right feeling at this particular time. And I thought that especially in the wake of Beryl and everything that, you know, we have gone through as a community, that this would be a good time for us to reflect on who we are and what we do and how we feel, and just pool our resources. Many times, most times, the community has adequate knowledge of what needs to be done. And so this is something that we can look at. So we're going to be putting our hands up for this presentation. I'm going to be asking for participation and all that good stuff. And many apologies that these hands are not properly pigmented. I pulled them from the internet where I got them, and next time I will try to do better. So we want to start, it would be great if my slides would go ahead. Let me see what I'm doing wrong. Okay, so we are going to have participation, and we're going to hold each other up and just be present together and share our experiences so that we can benefit from each other. We want to look at what kind of things have stressed us out. We want to look at what coping strategies we have used, because I'm sure that for the 500 plus of us who are on this call, there are rich resources for coping strategies. And some of what some people have, some people may not have. And we want to ensure that our strategies are relevant to what is culturally appropriate. And we want to look at strategies that may result in more stress. You know, we do something sometimes to help us relieve stress that result in us having more stress. And then we want to look at emotional intelligence and the relationship between that and stress. So we have a poll, and we want to just see how stressed we are in this moment. So I'm going to ask the doctor who is launching the poll to launch the poll, so we can just check in with how stressed are we right now. Are we really chill and relaxed and all of that? Or are we really hyped up or somewhere in between. So if we could have that poll, that would be great.
We're launching it shortly, Dr. Wilmer. Can
Okay,
you just
awesome.
give us, please?
Oh, that's
Good
fine.
afternoon.
Hi, good afternoon. How you doing?
I'm great. And you?
Awesome. I'm okay. And I think I'm about a 3 on this scale, you know, enough to keep me alert, but you know, and I got some stuff that I brought from home last time, you know, so
Ooh, wow. On
yeah.
Monday, I was 20 out of 5.
Oh my goodness.
Yeah, I was 20 out of 5. Today, I
Oh,
think I'm down to
wow.
9 out of 5.
All right. So we want to see what the collective group is like. And so let me you want me to pause while we do that?
Are we there yet?
Yes, we're there.
Another
Yeah.
second?
You sure? I haven't seen the poll, so.
No, we're putting it up. We're getting
Okay,
it up.
great. And so this is important because we need all the time to check in with ourselves to find out, well, how am I doing today? How do I feel right now in this moment? Because, you know, as people who are in healthcare, you cannot know what to treat unless you have some information. And so it is with your stress level. And as people in healthcare, you also know that your stress level is going to impact everything else, including diabetes, I'm told. So we have to just really be aware of how we're functioning and see, well, if I'm feeling like this today, then what do I need to do? What action do I need to take, you know?
Exactly, because when these stressors come from outside by our clients, we have to be at a level that we are able to take it and not break.
Right. Yes. So we have to take care of ourselves first before we try to do anything for anybody else. We cannot be pouring from empty cups, and we run the risk of doing harm to other people if we function in the capacities in which we work and our own stress levels are not properly managed. So we have to take care of that first. So we want to have self-awareness as a priority and an intentional priority.
Hi,
you
Dr.
know?
Dr. Fletcher.
Yes.
Hello. Hi, some persons are answering in the chat.
Okay.
So you can see the
Okay, so let me go to the
what
chat.
number
I
they're
love chat.
assessing their stress level at.
Okay. Oh, yeah. See, nice big numbers, 5 and 4, and yeah. These are stressful times. Yes. Thank you so much. Okay, great. Yes. All right. Yeah. Yes. Oh, I see that. So the numbers I'm seeing are big numbers, you know, so far. I have not seen anyone. So maybe we can do a poll towards the end and see how we're feeling. And so I'll just go ahead and ask for other information. So the participation has started, and we're going to be asking for more participation in the chat. Okay, so what is it that causes this? So we can put things in the chat of what is it that causes your stress level? What are the causes of this high stress level that you may have? What are the stressors that you have in any aspect of your life? I live in New York. One of the things that causes me stress is traffic, work. Yeah. And the nature of your work is stressful. It is just you holding lives in your hands all the time. Being an adult, adulting is really hard, and then you have to just keep doing it forever. And family, that is supposed to be good stuff. No, life expenses, money or lack of it. Somebody told me one time that so much money and not enough time, but for most of us, that's not the case. Family. So we have family, work, financials, infrastructure, kind of lack of resources, general life, being a grown-up and having responsibility, unemployment or underemployment, not bringing in enough. They should share that money, right? That's what I said. Like I can help you with that. Sickness, life overall, health or lack thereof, or fear, of health situations that might emerge. As I listened to the diabetes presentation, my whole thing went up because my doctor and I have an ongoing conflict. My numbers are okay, but he still wants me to take off weight. What is it with doctors and weight? I don't understand. Not enough time to do anything, including spend the money, health issues. So we have really a good pool of common stressors that are impacting us, essentially work, health, family. Relationships can be really very stressful because, when 2 or 3 are gathered together, you can probably have some stress. Okay, so the stress, how can you tell though, when you're stressed, it may impact you in different ways, like in your thought process, physically, emotionally, behaviorally. So you don't have to categorize any of these, but if you could just drop in the chat, how do you know that you are stressed? What is it that tells you that, yeah, I'm stressed? Okay, and I'll just monitor that. So I'm really expecting over 500 responses. Mood, physical. What do you mean by physical, Althea? Altered mood. Yeah. So some people have altered mood because they are excited or not so much, eating a lot. And for some people, it's not eating at all, feeling agitated, just not feeling yourself, getting short-tempered, and God help the people around you. Weight loss, fatigue, lack of energy, irritable, just flying off the handle for no good reason, can't sleep, crying, not caring, tolerance level, like 0 tolerance to foolishness, not eating, altered mood. Sleep is a problem. Getting ill, and having headaches and mood swings, happy and excited, and then all down in the dumps. Having headaches, difficult thought process. You know you're a professional, you know what to do, you know how to function, but somehow your mind is very cloudy, and therefore you're not coping as well with daily activities. And these may be work activities as well as routine, basic activities. Brain fog is a common symptom of stress. It's a common cognitive symptom that people are not really able to think clearly. So you see, if we have all of these impacts on us in different ways, and you get short-tempered, if you're short-tempered, then you might curse somebody out, or you might start throwing things, or you might just harm somebody in one way or the other. Tight neck muscle, shoulder. For me, it is across my back, across my shoulders and down my back that I have it in my body when I'm stressed. And so you must know where you have it. Some people have stomach pains and those kinds of cramps. Snap quickly or just shut down. Yeah, one extreme to the other. Either you're snapping or you just get quiet. And people are saying, what's the matter with you? Well, you don't want to know what's the matter with me because I might say something that you don't want to hear. So these are the kinds of things. So you can see that this is something that we really do need to pay attention to. I'm so excited about the participation. Thank you so much, because really, if you didn't put anything in the chat, then I would just have to log off and go have my coffee by myself. So I appreciate that. Thank you. Fatigue, changes in tone. I appreciate that. Thank you. So what strategies do you or other people use? So some people, you may want to share your strategies, or maybe some people who use some strategies that you don't use or would not use. So what are some common strategies that people use? And these can either be strategies that are useful or not useful, but what do people do? Go try to get some rest, sleep. Yeah. Work with the brain fog. Eat something delicious. Isn't that lovely? Don't tell the doctor who does the diabetes work. Take a vacation, Netflix, morning devotion. Prayer is a well-documented resource to help to relieve stress. Road trip. Watch a movie. Good. Music and meditation, exercise. These are nature walk. Being in nature is really important and very useful, because you're going to find that even the smells of nature help. My church recently did a mental health walk in a park, and we had all this nice vegetation and water and stuff like that. And it was really very helpful. Playing with doggies, that is one of my favorite things. I just have one doggie, and that is a great source of distressing for me. Yeah. Are there any things that's change of environment, nature, talking to somebody who can help and maintain your privacy? You see, that is a kind of a challenge, right? Who is not want to talk about your business afterwards? You have to feel really secure in that relationship. Support groups, friends and families. Beach is my other thing that I really can't get to do as often as I would like to, but that is a very powerful strategy. So one of the things we need to know is that it's different for everybody. And so while we pool these resources, somebody might say something that you might say, oh, I didn't think of that. I will try that out. Removing yourself from the situation, crying it out, music, all of that. How is it with saying, I wonder what you talk about crying it out. I wonder how it works with men and crying it out. Are we still at the point where we discourage our men folk from crying it out and just really cleansing their bodies of all this harmful, these bad feelings? Or is it a girl thing? You know, are we raising our boys with the ability to cry and the willingness to use that really great resource and to feel better and de-stress? They'll probably have a drink. Okay. And then to talk about having a drink, that is a great segue into other strategies. So these are, I hope, great strategies. I can see that you have really rich ways of helping yourself to feel better. And I'm really hoping that as these strategies are shared, then people are looking on and getting more ideas for other stuff that they can try. A staycation, we don't always have to like spend money and go far away in order to feel better. And thankfully, you know, beaches are very accessible and available, and all of that good stuff. So you have good resources and ability to use using. Spa day for me. Beverly Wright, are you my classmate? All right.
Sounds so to me. Sounds so to me, my dear. Wow.
Nice. Small world, big God. All right. So now, are there some strategies? Are there some strategies that people use that probably cause more stress, maybe cause some distress instead of de-stress? You know of anything that people do to relieve their stress, but can actually make things worse? And these are maybe strategies that we need to not use as much, or to consider shouting and fighting. Yeah, because these are destructive substance abuse. Yeah. Smoking, alcohol, sex, smoking, arguing, especially sex with strangers. That is just, you know, will lead to a lot more stress. Alcohol use of any substances, breaking things. I have a client who told me that by the time her marriage was over, she didn't have any wedding presents left because they had all landed against the wall. Alcohol and smoking. So we need to be really mindful telling people your business. So when you're about to talk your business, you need to find somebody who is trusted. And there are some people who have the training and the ethical responsibility to not repeat your business. So for me here, where I am, if somebody tells me their business and I talk about it, they can sue me. So, you know, it is really super important to really see if you can locate a professional with whom you can share situations that may be causing you to be stressed, because sometimes you may need a higher level of care that the beach can't handle. And so, you know, that is something to consider. So thank you for bringing that up. Overthinking can lead to depression. So we need really to be very aware of the anxiety and depression components of stress. And just be aware of what we can, the things that we can do, go ahead and like driving fast and so on, things that will put ourselves and other people at risk and can destroy our relationships or our lives or the lives of others. And consider using more strategic ways of being of handling stress. Thank you. All right, so emotional intelligence is a part of what helps for de-stressing. And I like emotional intelligence. And as I read this, I wondered whether emotional intelligence is a part of the training of physicians and nurses and other healthcare professionals in Jamaica, because it really is a part, it helps in decision-making, in choosing, well, how should I manage my stress? And it also helps us to have increased awareness of what is really causing me to feel this way and what I can do about it. So emotional intelligence is difficult to define, and all the research indicates it's really hard to pin it down, but there are two aspects of it to look at. One is as a trait, so to be inborn. And the part that I like is ability, because if there's an ability component, it means that we can learn stuff. And, education is really in my genes. And so we want to see how we can learn how to manage our emotions, how to express our emotions to others, how we can regulate our emotions, how we can use these feelings that we have as a source of motivation, how we can plan strategically to de-stress, so that we maybe create some kind of a schedule or make some kind of a plan with our vacation days or whatever time off or downtime that we have, so we can use that intentionally to do our wellness, so that when we, so we can just be alive. I mean, fundamentally, we want to be alive and healthy, and we want to be able to provide ethical services to the people who depend on us for that. So these are all of the research on that I found. I just pulled some research that was relevant to healthcare professionals, and they found that there are gender differences in coping, and we alluded to that. Like, are there some ways that men really manage stress, that women manage stress somewhat differently? And one of the things that comes up a lot in my practice and in the practice of my colleagues who I supervise is men and crying, men and talking about their negative experience, men on admitting that they're hurt, and they go towards anger because they cannot admit to pain. And so as we look at among you all who are healthcare professionals, men and women, I would encourage you to consider your own self-awareness and how you cope, and how gender impacts how you cope, and how you may be depriving yourself, if you're a man, of some of the awesome ways that women have of relieving stress, like having a good solid cry, and talking to somebody and really using the right words and admitting that you're hurting or you're scared, or these are things, right? So emotional intelligence really helps with stress coping and reducing maladaptive coping. It reduces the likelihood that people will choose ways of managing stress that will not result in relief of stress. So there's a relationship between emotional intelligence and maladaptive stress coping strategies, and all of the research is pointing towards that it is useful as a coping strategy against occupational stress. And I heard when you talked about work, and the nature of your work is stressful. There's just no way to get around that. Healthcare professionals just live in that space of being stressed and trying to keep people alive and well. And that is a big responsibility that you have. And so this is another part, another strength, another resource that you have to manage your stress. And for nurses, it emotional intelligence improved their work engagement and relationships with their colleagues and really made the working environment less stressful. So that's the information I had to share with you today. And so consider how you can tap into your emotional intelligence to strengthen your de-stressing, like increasing your self-awareness, considering how you can do emotional regulation. What kind of decision making can you have to choose strategies that will help you to de-stress? How can you use this information to motivate yourself? And how can you make a plan so that it's not, you know, like an incidental activity that you carry out, de-stressing activities? It's not incidental, but it is intentional and a part of your basic lifestyle. So that's what I had to share. So if you have questions, that would be our comments, then I would be open to
Wow.
that. And
Thank you so much,
okay.
Professor.
Okay, thank you.
So much for that presentation. I mean, I felt as if I was jumping up and doing jumping jacks and putting my hands over the air in the air, and
Funny.
I really felt de-stressed just by listening to how I should de-stress and not be distressed. And I can tell you that with the move from what cause and what should not cause, I am sure that persons would have taken away something very important from your presentation today. Thank you so much. And you so kept in time
Thank
so
you. I
that
see
I will
Khalil.
not lose the job today.
Is this Dr. Bullock's hand? I see a hand that's up, Khalila
I see
Bullock.
a hand, right. I was just going to indicate that Dr. Bullock has something to say. Can we unmute her, please? Dr. Bullock?
Hi, good afternoon. Thank you for the lovely presentation.
Thank you.
I had a question about the non-individual strategies. So a lot of the things that you highlighted were really what individual could do for themselves. I wanted to know, are there any effective or evidence-based strategies that the workplace could or should employ in order to promote the well-being of its workers and the coping?
Yes, so yesterday, some research was released from the United States that showed that the US workers had the highest number of unused vacation days in the world. I don't know how Jamaica works with that, but vacation days are built into people's contracts because you need them. So that is something that you need to do, that can be done institutionally, and that leadership can support. For my department, people, you know, my staff is required to take that time, and I will check on people to take time. For us, people also have to take religious, are entitled to religious days, and I have staff who don't want to take their religious days, and I have a conflict with them over that. Like, you got to take your religious days, go to your religious observance, go, don't be here. So that is one thing. Consider downtime, time that you can refresh and rejuvenate. We live in a culture that holds up as a virtue the ability to work 24/7. It's wrong. It's harmful for your mind, and it's harmful for your body, and it will kill you. And you can't really help your family, nor your patients, nor anybody if you're dead. So, you know, we can really, that is one of the things that we can do. Something else that did not come up as strongly is what came up a little bit is that is maybe for Jamaica would be useful, is that people participate in religious things, prayer, and you know, that sort of a thing. And I think this kind of presentation also is an institutional and leadership activity that invites people to invite somebody who is not only talking about who, in addition to your clinical work with patients, is also looking at how you can be well. So it's happening. It's happening. Thank you so much to leadership who saw it fit to include this in your work today. Thank you. So have a good afternoon, everyone. I hope that answered
Thank you
your
so
question a
much.
little bit.
And I too want to add my bit to it, because I saw somebody posted spa day, and last week being Nurses Week, I did have a spa day for my nurses here at the Spanish Town Hospital.
Awesome.
And I'm sure they thoroughly enjoyed it. And
Great.
I also sent for them Happy Nurses Week on the
Nice.
air, and it was aired and it was mentioned, and they were most pleased. We just need to have other persons buy in and help us along the way so we could cover more participants. But I think there's
Awesome.
another question that's in the chat. There's another raised hand.
Okay. Let me stop sharing.
Can we unmute that person?
Oh,
Just unmute and ask the question, please.
let me find my stop share thing. Where's my stop share thing?
You can go ahead and ask the question.
Yes, I'm listening. No? Any
The
tips on
person with the
dealing with?
hand up.
Okay.
Hello?
Any tips on dealing with stressful resuscitation or death in the young at work? That's the question for that. Yeah, that is a great question. And grief work, I'm a certified grief therapist, and grief work should be a part of the training of healthcare professionals. This is a very, very difficult thing to handle. It is very difficult to handle loss of life. In my profession, loss of life also happens when people die by suicide. And you need to recognize, I guess, first, that you must have done everything that you know how to do to prevent that from occurring, and used all the resources that you had, your professionalism, as well as all the other resources available to you. And sometimes we are helpless to prevent these things from happening. But the mind always goes to guilt before it goes to helplessness. And we need to recognize sometimes that we don't have the resources to do everything and save every life, which is a very difficult and painful thing. So that is something else. If we want to look at grief following patient loss, then that would be another presentation. But thank you. That's a very important concern for healthcare professionals. Thank you so much. All right. Okay. Thank you so much. Have a good afternoon, everybody.
Thank you so much, Dr. Wilma. And it's good to have you presenting again. And we're looking forward for your grief following patient loss in our next presentation.
Thank you.
So for our next up, we're going to be hearing from our sponsor. Today, a day like today would not be possible if we did not have sponsorship. So while we would have planned, a part of the planning was how we get sponsorship. And from Glenmark today, we have Anna K. Greenwood Brown and Tajay Ricketts, and there are two females who will be bringing us some words from Glenmark.
Okay. Okay. Hi, afternoon, everyone. My name is Aneke Greenwood, and I have with myself Tajay Ricketts. So today we're just going to speak a little bit about our products. For some of you will be, new knowledge. For some, it's a reminder. And, reminders are always good. So let's get into it. So who is Glenmark? What do you know about Glenmark? Let me just go to my slideshow. Right. So a little bit about Glenmark. Do you know about Glenmark? I can't even see if any questions or anything like that, but let me tell you a little bit about Glenmark. So Glenmark is a leading global research-based integrated pharmaceutical company. We're very much global as we have 12 manufacturing facilities in 4 countries. Some of these plants are located in the USA, Argentina, and Brazil. And we also have a US FDA-approved plant in India. We also have operations in over 80 countries. So that really shows we're really global, very, very global. Research-based as it relates to the amount of scientists we have, the tests that we do. We have over 250 scientists on board to assist in the development in new products. And let me just interject here that, we are what we call a branded generic company also, because we have some products, for example, the Momit AZ, which is an innovator brand. No other company has that kind of combination. So we can brag about that. We also have a research and development plant in North Carolina. We're integrated as we're involved in the entire manufacturing process from raw material to finished product. And all of these take place in FDA-approved manufacturing plants. We focus mainly on specialty and pure generic drugs. We have a lot of dermatology products, respiratory, and we have oncology lines, as well as, we have antibiotics, so on and so forth. Now, today, we're going to talk about 2 or 3 of our products. So you can know a little bit more about Glenmark, and, I will introduce and remind you of some of our quality products. One of our quality products today is our Canditrol. Now, Canditrol is Glenmark's itraconazole, available in 100 milligram capsules, and it's indicated for, onychomycosis, vulvovaginal candidiasis, as well as systemic mycosis. Now, that's a little thing now. There are many itraconazoles on the market, but what separates the Canditrol from any other itraconazole on the market is, the answer is there on the screen there. It's our unique pellet technology, our double-coated unique pellet technology. Now, our capsules are red and white capsule, and in that capsule are some little beads, some white beads. Now, this is just like a transverse section of what the beads look like, what it's made of. So on the outer layer, you have the UGRIT 100, which really increases dissolution. So it aids the active to be dissolved quickly, as well as it prevents and protects gastric irritation. Because as you know, sometimes patients taking antifungals, they say they have gastric irritation. But because of this UGRIT 100, you have protection against that. Followed by the hypermelose, that is the second layer, and that prevents recrystallization. And it also ensures that 100% of the drug is delivered to the site of absorption. And it also enhances dissolution rate. Then you have the sugar bead, then you have the itraconazole molecule itself, that's the active. Now, all these features, what are the benefits of these features? Like, why am I telling you all of this? So now the benefits of these features now is that it aids in disintegration and absorption of the active. So you can see that disintegration is within 15 minutes. Absorption of the active, the itraconazole, is within 30 minutes. So you can say within 30 minutes, the patient may start to feel symptomatic relief, especially when you're treating a vulvovaginal candidiasis. Within 60 minutes, you have dissolution, maximum dissolution, and in 1 hour, 30 minutes, you have maximum absorption. So of course, it starts to work at that time. Now, the Canditrol, it's highly lipophilic, so therefore it has a higher bioavailability in the affected areas, and also highly keratophilic, which makes it very excellent in treating like your tinnias. So your tinnias, your tinea cuparis, versicolor, tinea versicolor, also your in onychomycosis treatment. So like for your dermatitis, treatments is 1 capsule daily for 15 days or 2 capsules daily for 7 days. It's also recommended that for onychomycosis, it's done pulse therapy. Pulse therapy for the fingernail is usually for 2 months as opposed to the toenail, which is about 3 months because, you know, toenails take a longer time to grow. Now, when you talk about your vulvovaginal candidiasis, you know, you may have a lot of patients that come in, you know, you have the recurrent cases. Now, the canditrol is one that is proven to even prevent the recurrent cases of your vulvovaginal candidiasis. Now, here, that's a little study. I'm just going to summarize and get through, you know, quickly. It's really a comparative study that was done to compare the efficacy of fluconazole 150 milligrams stat versus itraconazole, the canditrol, 200 milligrams BD for the treatment of acute VVCs. Now, the study was carried out on 60 women with clinical and mycological diagnosis for vulvovaginal candidiasis. The groups were divided into 2. You have group 1, group 2. Group 1 was treated 150 milligrams stat of the fluconazole. Group 2 was 200 milligrams BD of the itraconazole for the day. Now, on day 7, they were assessed for cure and relapse on day 21. Now, these are the findings that we got. So the graph on your left, I guess that's the comparison of the treatment with response to itraconazole and fluconazole. Itraconazole, which is the canditrol, that's in the blue. Fluconazole is in the red. You can see where you had a higher clinical cure rates for those patients that used the canditrol. You had lower failure rates and you had lower relapse rates compared to your fluconazole. Now we move to the other graph that's really tells you about the efficacy of the fluconazole as it relates to the treating of the symptoms. Now, we know VVC, so women, you know, it can be very uncomfortable. That's the reality, very, very uncomfortable. The symptoms associated, the itching, the burning, you know, you have the vaginal discharge, affects your quality of life. So you want to ensure that when you are prescribing something for your patients, you're going to improve the quality of life for your patients. No, that's what you get with your canditrol. So in the graph here, we can see that, of course, the canditrol is the one in the lighter color. Let me just verify that. Yes, the canditrol is in the lighter blue. Fluconazole is in the red. And you can see that for the vaginal discharge, itching, burning, etc., there was a decrease in your patients compared to your fluconazole. Now, the indicate for treating vulvovaginal candidiasis for acute cases, it's recommended 200 milligrams BD. So that's for 1 day, 200 milligrams in the morning, 200 milligrams in the evening. For your recurrent cases, it's required that you give the patient 200 milligrams once daily for 3 days. And as a prophylaxis, they take 200 milligrams on the first day of the period for the next 6 periods. Now, in addition to, you know, improving the quality of life for your patients, you also have to ensure that, you know, it's something very affordable. In our economic times like these, we have to ensure that we're giving a drug that not only works and is very effective and of great quality, like Glenmark, but also very affordable. And I'm pleased to let you know that the canditrol right now is the most affordable itraconazole on the market. So once written by name, and they go to the pharmacy, your patient will be benefiting. It's like a total 360 worth of benefit for your patients, right? And just, you know, to sum up everything, this is a part of our antifungal line. We have the oral antifungal, which I just spoke about. That's our canditrol and 100 milligram capsules. Then we have our inserts. We have the Candid V3, that's a 3 nights insert. The Candid V6, that's a 6 nights, and we have the V gel. Now the V gel is also for 6 nights. What I usually really recommend the V gel for those patients that have intense burning and itching on the outside. So what happens when the gel does come out, it's soothing to the patient. It actually soothes the outside of the vagina. In addition, it's not here, but I wanted us to remind you too of the Candid powder. The powder can also be used in the toes, like, you know, even for jock itch on submammary areas, the athlete's toe. I know right now the time is very hot. So there is no doubt in my mind that this line of product will become very beneficial for your patients. All right, is there any questions about the presentation before I hand over to
My teammates? Anything there? Okay, everybody. Right. Taji, yeah, man, she's home. There's a question? A spray? Oh, no, just the powder. And we have a candy lotion, candy bee lotion preferably.
Yeah, I'm ready. Yeah. All right, guys. So as you can see on your screen, we do have our Keto Plus. And our Keto Plus, as most of you guys may know, is our shampoo for your patients with dandruff and seborrheic dermatitis. Now, Keto Plus contains ketoconazole and zinc. So basically you're getting a dual action from our Keto Plus. So ketoconazole is the broad spectrum antifungal, getting rid of the fungus, and zinc is a bacteriostatic, fungostatic agent, getting rid of the flakes and preventing the reformation. Now, when you have a patient come in with dandruff or seborrheic dermatitis, we'd like that you recommend Keto Plus on the scripts by name for your patients, because when your patients go to the pharmacy, of course, this is what they will get. If you write the plain ketoconazole on the scripts, when your patients go to the pharmacy, they will not get our Keto Plus, and of course, they will not benefit from the zinc that the Keto Plus contains, which helps to get rid of the plagues. And your patients will be coming back, and we do not want that. Of course, we want to improve the quality of life for your patients, so you can just recommend Keto Plus on the scripts by name. To the right, you'll see where I have a graph comparing the cure rate of the ketoconazole and the Keto Plus shampoo. So the Keto Plus would be the brighter blue. So basically, patients have 97% more cure with Keto Plus than with the plain ketoconazole shampoo. So once a patient come in with dandruff or seborrheic dermatitis, please remember to recommend Keto Plus on the scripts by name. And not to worry, it's not expensive. It's quite affordable. We sell Keto Plus to the pharmacy for only about $1,200. So of course, your patients will be able to afford. We're moving on to our Glenset because, of course, it's really hot now and patients will be coming in with allergic rhinitis. We here at Glenmark, we do have our levocetirizine, which is our Glenset for your patients with allergic rhinitis. Now, our Glenset, as you can see in the table here, has a faster onset of action than the Loratadine and the Fexo, which is 3 and 2 hours respectively. And it also have a longer duration of action. Below you can see where we have a graph where patients have effective in treating allergic rhinitis symptoms. So when you recommend the Glenset, the symptoms, there are significant reduction in the mean symptom complex score for your patients. And this is done in a shorter time. So once a patient comes in with allergic rhinitis, please recommend Glenset on the scripts by name again, of course. So that's what your patients will get at the pharmacies. And not to worry, Glenset, we only sell for about $50. Well, pharmacies sell the Glenset for about $50 per tab. And your patients can also get it OTC. So once you prescribe it for them, you can just let them know. You can always go back to the pharmacy and ask for the Glenset by name. All right, so this is just a little thing for you guys to remember Glenset. So it has Say With Me, So basically, to start my day free from allergies, all I need to remember is ready, Glenn set, go. And that's all you need to remember to just recommend the Glenn set for me. So once your patients come in with allergic rhinitis, of course, ready, Glenn set, go, and your patients will be good to go. And we'll also have our superosin, which I know is not new to most of you guys, but we just have to remind you guys. So for superosin, you know, you can recommend it for your patients with burns, with boils, with leg ulcers, and for all your bacterial infections. Now we have a graph here which basically show that our superosin is superior to fusidic acid in treating SRS infection, and you can see in the graph that we have here, comparing the superosin and the fusidic acid. Or superosin also have a higher bacteriological cure rate than that of fusidic acid, and you can also see it here where the cure rate of our superosin is 97% as compared to that of the fusidic acid, which is 87%. Also, our superosin facilitates wound healing process, and it's the most effective treatment option in reducing staph colonization. Superosin can also be prescribed for your patients with bacterial infections. And again, we're just comparing here. And for your patients that comes in with the impetigo, you can also recommend superosin for those patients. And patients that have secondary infected eczema, or superosin provides greater bacteriological cure rate compared to the oral cephalexin, and it provides excellent coverage against SRS. Or superosin is more efficacious than fusidic acid in treating impetigo. So again, we're just asking you to recommend superosin on the scripts by name. Superosin is available in drugstore. However, we still want you to recommend it by name. So when your patients go to the private pharmacies, they will get our brand of superosin. And I am almost finished, guys. Just the last slide, just reminding you of our superosin B, which is a combination of betamethasone. So for if there's any inflammation, you know that we have our superosin B. You can always recommend it to your patients. And in choosing Glenmark's products for your patients, you will be assuring them high quality, affordability, accessibility, and of course, sure results, because Glenmark, we only provide quality products. Thank you for your time, guys.
And thank you for your presentation. There are questions, I think, in the chat.
Yes, superosin B is recommended for patients 12 and older, whereas the plain superosin is for patients 2 months and.
Thank you so very much. As I said, we could not have gone through today without our sponsors. So we want to thank Mrs. Anna K. Greenwood Brown. Did I get that right?
Yes, you did.
And Ms. Tajay, female. Mr. J is female. She's Tajay Ricketts for their presentation. Of course, we learned today about Canditrol, Keto Plus, Ready, Glenn, Set, Go, and Superosin B. So at least we got our information. We can get it right. And they did say, order it, and they will have the best benefit. Our patients will benefit profoundly. I am seeing we're down to 442, but we're looking at 4 hours now instead of 3 CME hours. So our hours are going up the longer that we stay here. But we have one more presentation. And I don't know if it's because it's the greatest. I'm not sure. At the end of it, then we will see. Our last presentation is on decision to consent. And it will be done by no other than one of our household names, Dr. Caroline Pinnock Jackson. And Dr. Carolyn Pinnock Jackson completed her MBBS and DM in pediatric surgery at the University of the West Indies. She worked at the Bustamante Hospital for Children, and I could put in along with myself, for 10 years, after which she moved into full private practice. She has a keen interest in all things abdominal, training in learning laparoscopic surgery, endoscopy, and colonoscopy, as well as allergy testing and immunotherapy as tools for helping to solve the mysteries of childhood abdominal pain. Committed to holistic health and wellness, she studied pastoral counseling and is the founder of Jamaica's first child and adolescent wellness center, Caribbean Thoughts to Teens in Ligonier, offering mental health, school assessments, and nutritional services for all children from birth to college. Dr. Jackson has participated in multiple informal local studies presented at local and international conferences and has been published in international journals. She currently offers concierge daycare, surgical services, and more at Kiddie Care. At Kiddie Care Pediatricians, and now has new interest in the management of hypospadias. She enjoys serving families from all over the Caribbean. Please help me make welcome Dr. Carolyn Pinnock Jackson with the decision to consent.
Good afternoon. I have been unmuted. Can you hear me? Hello?
Are we hearing her? Yes, we're hearing you, Dr. Jackson.
Okay, excellent. So I had spoken about informed consent recently with Spanish Town Hospital, but there has been a lot of interest and discussion since the $100 million case awarded from a patient at Western Region. I don't know how many people in our meeting actually read about that case or heard about the case, but there is a significant element of consent involved in it. And so Dr. Wright James had asked me to come to speak about consent, particularly in different settings and different scenarios, and I focus a little on in the emergency setting here. So I'm going to talk about what is consent, and I'm going to focus a lot on the importance of alternatives and options in consent. I'm just checking the chat. Okay, great. I'm going to talk about a few cases in the emergency setting, and then what can be our next starting point. So what is consent? Consent is, in its truest etymology, is for us to all be in agreement, which means that we all have to have the same level of knowledge in order to agree. And the types of consent, as we know, can be implied or explicit. And particularly in the emergency setting, sometimes it is a matter of opting out in terms of if your patient is unconscious, if there's no one else to be able to give the support that you need. And of course, the value of consent is far-reaching. It makes sure that everybody understands what's going to happen. It allows the patient the primary opportunity to participate and agree in their medical care. And a lot of the cases that have been awarded significant amounts in the Jamaican judicial system have, the highlight has been that the patient was not allowed an opportunity to participate in the discussion. The doctor made the decision for them. And it is important to note that these decisions may have been life-saving, The operations may have gone exactly how the doctor hoped, but because the patient was not allowed to participate in it, their right to refuse treatment or to choose a less effective treatment was taken away. And so the consenting process is something that we absolutely have to review as a fraternity. So in this slide, we talk about consent requiring 4 things. The person who is consenting must be competent. They must be voluntarily selecting to participate. They must have the full information about the process, and they must understand what they are being told. But there is an important, a critical element that is missing from this. And I would love if anybody in the chat could tell me, what do they think is missing from this requirement for informed consent? We have included competence, voluntary nature of it, fully informed about the process, the risks and the benefits, and understanding. What could possibly be missing from this consent process? A witness. Aha, Dr. Kathy Mae Dockery got it right. The alternative options is the big thing that has been really affecting our Jamaican decision making. What the alternatives are. It is not sufficient to explain to the patient your recommendation only. We must, as physicians, also explain what the alternatives are and their risks and benefits, and the alternatives must essentially include doing nothing. So I think a lot of times we inadvertently mention what will happen if you do nothing, but we do not make it an important part of our consent process to discuss what the other alternatives are. Alternatives and options. The recent rulings in Jamaica have really demonstrated that alternative treatment options within the institution and also privately must be shared with the patient. It is an instinct of ours to help to frame the patient's decision based on assumptions that we make about their ability to understand and their ability to pay. And so there are many circumstances where we simply will not let patients know that there are alternative options that are not available in the government system. And there have been Jamaicans awarded millions of dollars because the physician made a conscious or subconscious decision not to inform patients about what was available privately within Jamaica, but not within the government system. It is of note, it is important to note the importance of exploring all the possible diagnoses. And the most recent case with the $100 million award, the patient had surgery for a specific condition, which was clearly proven. The surgery improved that condition. However, the condition did not completely eliminate all of the patient's symptoms. And it turned out that the patient actually had more than one process going on at the same time. And the patient sued and won because the doctors who treated the initial visible condition did not explore with the patient that there were other possibilities and other diagnoses that could have caused this exact same symptomatology. And so it's not simple in terms of, I am going to do X for you, this is what is going to happen. We are called upon, and the judicial system notes that it takes 2 important things that we hardly have in government system. It takes a lot of time for a physician or more than one to sit and explain to a patient what all their options are, including the risks and benefits. But the other thing it takes is physician education. And how often do we implement training programs for those persons who are new to our team, whether it's a new intern, a new resident, or even a new consultant, to be able to speak to what are the guidelines that offered through your institution. So the rulings specify that it is important for the patient to understand, and it implies that as a medical profession, we will do the background work to ensure that everyone on our team who is involved with consenting understands all the components of consent. So a lot of times we as doctors want to focus on explaining complications and explain so that the patient will not be caught unaware. And we like to focus on the procedure and what it is we are going to do. That's where our strength is. But it is important to note that patients may not necessarily be as interested in what we want to explain, and they may have their own points of interest, which they may not bring up. So in the conversation of consent, it is important that we're able to tease from the patient what their concerns are. And this can help us to highlight complications or outcomes that may be minor, that may be rare, that may not be a part of the routine consenting process, but are significant to this particular patient. The law requires that we attain good informed consent, and it is important to note for this year, every judgment that has been made in medical negligence has held no value to the general admission consent for consenting for procedures. So what I mean to say is that the judge will note that the general admission consent was signed, and the judge will make a comment that this signature simply means that the patient agrees to be worked up and prepared for whatever is to come. No judge has considered, even though the documentation specifies surgery, anesthesia, treatment, so on and so forth, no judge has considered that consent form sufficient for any procedure beyond the basic blood taking, x-rays, blood pressure monitoring, and so on. So it's very important that we understand, regardless of what the form says, our legal system does not view it as a consent for procedures. Lack of consent can actually be treated as assault in the court if a patient undergoes a procedure without wanting to have the procedure and expressing that they did not want to have it. But it can also be charged as negligence from the point of view of if the procedure comes up in a way that the patient is unable, for example, during an operation, you may discover unexpected pathology, but if you did not have an open enough discussion with the patient about the possibilities during the operation, then that will be considered negligence in that you failed as a physician in your duty of care to highlight all the possibilities that could be of concern to this patient. And it's important to note that the court does not require that you highlight every single possible complication. In fact, in the British system, it is not required to mention infection as a complication because infection is assumed to be a risk of any operation. Where that's something that we talk about quite a bit within the British system, it is not a requirement. But if a patient is female and of childbearing age, discussion about how a procedure may impact their ability to have children, even if the procedure is not gynecological, is still significant for many female patients. So a lack of consent is not simply that the patient did not consent for the procedure, but that the full extent of the patient's concerns were not explored, and therefore we will be seen as negligent in our duty of care. So we know that the general consenting process should include talking about the diagnosis, a description of what's going to happen, the possible interventions, and you see I have here any big unexpected possibilities. What is big and unexpected for us may be very different to what is big and unexpected for the patient. And so it is important to include the patient in the discussion to find out what their concerns may be. The other very critical thing is it is important for us I have here the Dr. Boo discussion. Dr. Boo is a mnemonic for description of the process, risks, benefits, options, and outcomes. It is very important that there be an independent note in the docket of the patient, within the patient's admission notes, clarifying what risks were outlined to the patient, what the options were for the patient. This is very important. A signature on the consent form alone does not speak to the actual discussion. Ultimately, I think it would be important for us to redesign our consent forms so that the form has a blank that we can simply fill in what the risks were that were discussed and what the options were that were discussed. But at the moment, it is essential documentation that is expected as we speak from our judicial system that whoever is taking consent from a patient for a procedure or for an intervention that is complex must include in the document, in the documentation, in the patient's file, what risks and benefits were discussed with them and what options were discussed with them. So in an emergency setting, things can be quite different. And so we remember consent in emergencies can be implied, it can be explicit, it can be opt-in, or it can be active. A lot of the information that we need to be able to give patients advice about what happens in our institution is not available to us. And this is a song that I will continue to sing because we must advocate for having our institutional facts available. We have been operating as a healthcare service for decades. We have decades of information, and I think it is irresponsible for us to not be able to speak to what our institutional experience actually is. There are a couple scenarios that I want to just run through, and I see some of the comments in the chat, and I'm definitely going to be addressing those later in the presentation. So I'm glad to see you're all thinking how I was thinking. But let us talk about, these are 6 scenarios in the emergency setting and how this discussion of the consent process would apply. In an unconscious adult who is in imminent danger, for example, a 21-year-old man jumped from a moving bus because he felt he had missed his stop. He was caught in the wheel of the bus. He was dragged for a bit, and then he ended up coming to hospital with a mangled limb. He is unconscious with a mangled limb. He is unstable, bleeding from the limb, and the decision is made to operate and remove the mangled limb and save his life. In the chat, can you tell me, do you think that is an appropriate decision for the emergency staff to make? So overall, if the adult is unconscious and in imminent danger, so if we do not remove this mangled limb, he will bleed to death. It is reasonable to proceed with a life-saving procedure. It is implied consent, perfect. It is, the consent is implied by the fact that his unconscious body is at the hospital. It is implied that whoever brought him there wanted him to get care. Now, in another situation, we have, if instead of being 21, this was a 7-year-old and the parents had not yet arrived at the hospital, but the child was bleeding to death, would it be appropriate to continue or would it be necessary to wait until the parents return, until the parents can be found or some family, some relative can be available, considering that the delay could cause the child's life? Right. So the proper decision in the emergency setting is definitely to save life first. It is life before limb. And in that scenario where the child is not going to survive an unknown amount of time to find the parent, it is acceptable to go ahead with that type of intervention. The parents may sue, but the court will support the physician who has made a decision to save the child's life. Okay. Now let us talk about a conscious adult who does not wish to have any form of intervention. For example, a 72-year-old perfectly sensible retired lecturer has has a femoral aneurysm. The leg is now dead and the leg is impacting his vascular system and he's going into septic shock. His family brings him to hospital and he says with his fully conscious and sensible self, I do not wish to have surgery. If this leg is going to kill me, let it kill me. Do we have a right to intervene and remove that leg? That is correct. Once somebody is conscious and cogent and old enough to give consent, we must acknowledge and respect their desire to refuse treatment. That is correct. We let the limb kill him. It is his limb, it is his life, it is his decision. So the question was, suppose this gentleman is not cogent. Suppose it is that the sepsis is affecting his ability to make a decision. So I am specifying that he is fully cogent, fully capable of making decision. And that's the decision he makes. And yes, indeed, he should sign to that decision. A note should be made in the same way that you make a note for the other things. A note should be made about the discussion of the risk, a discussion of the options that are available to him, and he can sign to say that he refuses consent. And that decision holds even if he becomes no longer cogent. Because it's his decision will always outweigh the decision of his family. So I saw that in the chat. The conscious cogent adult decision will outride anybody else's decision to speak up on his behalf when he's no longer able to do so. In the scenario now with the pediatric patient, who wants treatment and the parent do not wish for them to have treatment. So let us take, for example, the family for religious reasons does not accept blood transfusions, and that's a very popular scenario in this type of discussion. The patient is 15 and the patient wants to receive the blood transfusion, which is not life-saving, but will significantly improve their outcome. And the family of this 15-year-old said, no, it is our religion that we will not give it. In a situation like that, where a conscious, cogent pediatric patient who is of age to understand what is happening to them differs from the parent, do we have a right to go ahead and treat, or must we withhold?
The state should get involved, and we take it to court. Yes,
that is correct. Even if the child is a minor, if the child has expressed assent for treatment, the court can grant them the ability to override their parent. And in that situation where it is not a life-threatening situation, then the case should be taken to court. That child should be given an opportunity to speak for themselves, and the court will decide based on their assessment of the child's maturity and the parents' leaning what the ultimate decision will be. So even though the child is a minor, especially if they're over 12 years old, 12 is a generalized cutoff number within the court system for you to be sensible enough to speak for yourself. And in Jamaica, we have had 12-year-olds who have committed murders who have been charged as adults because of the court's assessment of their maturity. So a child who differs from their parent can have their opportunity to speak up on their own behalf, as long as it's not a life-threatening situation, simply because the court system is not something that's going to happen in a 4 or 6 hour period, right? If a conscious and mentally incompetent patient refuses treatment, do we have a right to override and restrain this patient? Restraint is a very particular thing. And from a restraint from a legal point of view impedes your liberty. That is the legal definition of restraint. It impedes your liberty. And the question is, does the restraint limit your liberty, or does the restraint eliminate your liberty? So if somebody is drunk and boisterous and can't sit down for you to dress their wound, and you tie them to the bed to do that, and then you release them, that is restriction of liberty, but it is not a denial of liberty. Whereas if you have prolonged tie down a patient in a bed over a period of days because they keep pulling out their NG tube or they keep pulling out their IV, is that a breach of their liberty? It could be seen as a breach of liberty, and systems should be in place to manage that. But in the emergency room setting, a conscious, fully drunk patient comes in and is refusing treatment. They're able to speak, they understand what you're saying, but they're clearly inebriated. Do we have a right to override that patient? So I see in the chat that most people feel, yes, this person can be overridden. Do you have in your emergency room a system for determining whether or not someone is mentally competent? Are you required to call a psychiatrist? Is it something that the emergency doctor can follow through on a checklist and make that decision on their own? Is there anybody from emergency room in here? Ah, here we go. So clinically, the emergency doctor can document their decision or document the characteristics of the patient that cause them to make their decision. If it is not an emergency, then you can call on the psychiatrist. If it is an emergency and the emergency doctor feels comfortable to make that decision, they would. Okay. All right. I'll go through the other questions in the chat afterwards, but I know you guys have been here long and it's warm, so I'm just going to slide on by. But I think overall we have a good understanding of how to apply the rules and regulations, and I'm glad that we were able to talk about advocating for the pediatric patient, because just because you're under 16 doesn't mean you don't have a right to participate in your healthcare, and that's something that I'm a huge advocate for. So now my questions to you. With our current content process, which we all know that document really serves no living purpose, and most of the times it's photocopied, the words aren't even clear, some of it is missing. Who wrote that form? Where did it come from? And how long has it been in our system? And I think it would be easy for us to assume that that has been in the system from probably the days of slavery, because clearly you didn't have any rights at the time. Nobody cared how you felt about it. The doctor said do X and X was done. But I would love for you to consider what are the changes you would love to see on that content now. And who on your current team can help to guide that change? Because even when a patient signs that form, we as physicians have to start changing our documentation in the docket right now. Right now, that documentation has to change. As of today, as of this minute, we have to write down in more detail, and not that it requires long sentences. It can just be risks, bullet, 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 benefits, bullet, 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 options discussed, bullet, bullet. That is sufficient, but we have to start writing that down. Who on your team can guide how that change is implemented? So when the government takes it on a broader scale, we already have mechanisms that we're using that we can show are effective. Is there somebody on your team who can do that? Is it something that is worth for the team to discuss?
Yes, Dr. Jackson, our SMO is right here.
I'm not putting it on the SMO. I think it has to be whoever is doing the procedure needs to be able to speak to those things.
Her heart is with pediatrics, so she has a point there as to score as well. So I know she can competently guide the team, and on a national level, because it's not just for us at Spanish Town, but all over, because I have been looking at it. I saw a consent form where the doctor wrote it was a whole foolscap. And I'm saying I'm sorry for that poor doctor, and he could have just missed something, but if we had everything there, it would have been so much easier. But I had to commend that doctor when I saw the patient's file and all the listings that were done there. And if we had a form, it would have been much easier, a standard form. So the standards committee, as was mentioned here, I wrote it down, can take that charge. And I know my SMO is competent to sit on that committee.
I'm very glad to hear that the standards committee is actually involved in that. And I do think that there has to be procedure specific as well as less specific, because not every procedure is not every procedure is common enough that you have a specific consent form for it. But putting those things together in the US, there are actually entire companies that will go into a hospital, do this work, interview the people, and create the documents for the staff to use. And it allows anybody who is trained on that team. So a doctor, a nurse, even well, no, not unregistered persons, but doctors and nurses can use that form to explain to patients and to have that consent signed. But it's definitely something that we must change. And I really hope that everybody here can become an advocate for that change. But a part of it is we have to be able to say what our outcomes are. And I have no idea how any institution in Jamaica can really speak to that. It's something that we really have to look at and have a champion within each group to be able to fight for it. My last slide, we also need to change how we orient our new staff. As I said, every new nursing student, every new medical student, every new intern, every new resident, every new enrolled nurse, every new registered nurse, every new person on the team needs to get an orientation of what the common procedures are, what the common risks are, and what the alternatives are. I can tell you, when I was an intern, what you caught, and what you didn't catch, you didn't catch. And we have to change how that happens for the patient, because the patient deserves a fulsome opportunity to make decisions about their health. So we do ultimately want to work towards written guidelines for use with each consent. Whether it will be written, video, swiping of slides, I don't know, but we have to change how we are communicating with our patients. And it starts even before the formal document changes. We have to start by writing down in the docket what we are doing. So I really love that you guys are asking some excellent questions in the chat. I'm going to go in the chat and see, and if anybody wants to ask a question up front through Matron, that's fine with me.
Awesome presentation, Dr. Jackson. Awesome presentation. It was worth the while for us to wait and to get all 4 hours for today instead of 3. You would have seen the questions that are there, or were they just in keeping with what you were saying at the time?
I think so far we've talked about most of it. One person asked, would each hospital have a different consent form? And I think ideally it should not be. The procedure that you receive should be standard regardless of which hospital you're receiving it at. So that would be an important part of standardizing, and which is really why the standards committee is who should be intimately involved with this. Yes. I'm going to mute now. Thank you very much for having me. And I hope that you enjoy the rest of your day and have some cool breeze in the evening.
Thank you so much, Dr. Jackson. I think Professor Fletcher Anthony also had answered some questions. I don't think there were any questions there, and throughout, I think the questions were answered. Is there anyone else with a question before we move on? Because we have gone over time, but if you have a burning question, you can just raise your hand and we'll just take it, because we want you to leave here today really sharpened, not just your edge, but right throughout. Any last question? Please remember to complete the Google Doc form that is placed in the chat. That is how you will receive your CME hours. And I see patiently waiting is our wrapping up director. Our wrapping up director, Dr. Roger Smith. Welcome. Is there, I understand that there's a raised hand. Mrs. Taylor Smalling. Mrs. Taylor Smalling, you can unmute and go ahead.
Good afternoon, DNS Robinson.
Good afternoon.
And thank you so much, Dr. Jackson, for that awesome presentation. To me, for the information she gave, the one that was omitted, I think it is not new, because for our consent, we speak about informed consent, which include all of those. As she spoke about orientation, which is extremely important, not to be biased, but I know nurses usually do very good orientation. But I think what we need what you call it? We need persons to guide. There's mentors. I think we need mentors. That is one of the big things that I think we need. Because as it relates to this consent form, and as I mentioned in the chat, there's a standard committee that speaks of things like these. And when they meet, they will discuss, they will write the forms, rewrite the forms, and it goes through the Ministry of Health. And all of this will address all the hospitals. You will not have a separate consent form for each hospital. But as they go through all of these, it goes to the Ministry of Health. So a lot of times it seems like things are new, but they're not really new. We need to go back, look at what we have. And as she said, for this particular consent form, though, the court is not accepting the combined thing that we have in that consent form. So that maybe we need to address. But I think we do know a lot of things. And I think what we really need, we need mentors. Thank you so much.
Thank you so much, Mrs. Taylor Smalling. Very good points that were raised. And just for us to go back to our information present and to build on them. And I am quite aware of the Standards Committee. Dr. Smith, we're just asking for you to wrap up our 4-hour session.
Good afternoon. This is the wrapping up director. As Matron said, I must commend all the presenters on really good presentations. This was a particularly interesting meeting, and the presentations by themselves, they weren't just information. I think each presentation was a kind of a call to action, both on a personal level and an institutional level. Diabetes, one of our major risk factors for cardiovascular disease, it's a driving force in driving up the cost of healthcare. Each person can be responsible for helping in that fight. And some of the things that Professor Boyne spoke about, it would have been some time for some people to have heard, since they have heard some of those things. And a refresher is always welcome on diabetes. Risk intelligence, everybody is responsible for risk intelligence. That is what I learned. It's not just the head of the hospital, it should be in the fiber of your being if you want the institution to do well. De-stressing, we can't emphasize enough how stressful our lives are. Medicine is one of the most stressful careers. Doctors are among the highest group of people who commit suicide, all right? So this is very important. We must make time for ourselves, and we must make time for the right way to de-stress in a healthy way. Consent is at the core of medicine. We cannot practice medicine without consent. All of our consent forms that I have seen are inadequate, and I'm very glad that somebody else thinks so. I think that if anything from this meeting that is of vital importance is that we move ahead with working on these consent forms before something catastrophic happens. Awards of $100 million cannot be paid out willy-nilly, all right? These are preventable things and simple things to prevent. It's all about communication and recording the communication. I'd like to thank the audience for staying with us this long. And I'd also like to thank the sponsors and organizers for making this meeting possible. Good evening.
Thank you so much, Dr. Smith. I need to thank you for thanking all, but from my end, I need to say thank you for all 349 participants who are left. I do hope that you would have placed your information in that Google Doc that was placed in the chat over and over, because we are quick on our action. We work just as soon as we're finished to put together your hours to send out to you, because we know some people are here for the hours, or while some are here for the hours and the information. We thank you so much. Thank you so much to our presenters, all four presenters, Professor Boyne, Dr. Stephanie Reed, Professor Wilma Fletcher Anthony, and Dr. Caroline Pinnock Jackson. But today would not have been possible without the technical team around me. If you notice today, it was flawless. We had no glitches from our ends. And that is a fact. I've been sitting here for quite a few years, and we were flawless today. No band change went on. There are times when I think we had band change. No flaw from our end. So I want to thank the technical team. I want to thank the persons who put today together. But most of all, I want to thank not just our sponsors, but the person who put today's session together. I am sure every single aspect, every single information today from all the presentations were well received, and you would have gone another 4 hours if we didn't have a time limit. So I want to thank our SMO, Dr. Jacqueline Wright James, for putting together this third session for 2024, our free sessions with your 3 CME hours on a normal basis, 4 for today, and we look forward to our 4th webinar. My name is Novlet Robinson. It was my pleasure to be able to chair this session. Thank you ever so much.